Hello guys, welcome to our channel. Today we are going to discuss about the part 2 short series part 2, and in this we are going to discuss the remaining 50 topics, and after that tomorrow another short series will be released. So this 150 topics, more than 150 topics, which will be comprising all important PYTs and expected topics guys. Please, those who have missed the short series 1, please go back and watch that video and also watch the tomorrow's video. Okay, let's go into the today's discussion. So again, let's start with the first anatomy, the most important anatomical triangles. Here you can see this is the cubital fossa. Okay, we are looking at the cubital fossa. In that you have to take note of the borders. Okay, so the superior border here you can see this is the epicondylar line, and the medial, this is the medial line which will be comprising of the medial border by the pronator teres, and lateral side the border is by brachioradialis. Okay, this is the border that is present in the cubital fossa. Then coming to the content, what is the content that is present in the cubital fossa, which will be important question guys. So the mostly you have to remember by the mnemonic of MBBS. Okay, this has to be remembered by the MBBS. So the first M is for the median nerve. Okay, this is for the median nerve. Here you can see this is the median nerve, that is the content present in the triangle. Next, the B is for the brachial vessels. Okay, both the brachial vessels, which will be artery and the vein. Here you can see this is the vein and this is the artery. These both are brachial artery and the vein. Next, another B. Another B is for the biceps tendon. Okay, so this is for the biceps tendon. And next, what about the S guys? S, which will be important for you to see, this is the superficial radial nerve. Okay, this is the superficial radial nerve. Right, this is the content that is present in the cubital fossa. Next, coming to the another important structure here. What is this structure guys? Femoral triangle. Okay, this is femoral triangle. So in the femoral triangle, again the borders are very important. So the superior border is by the inguinal ligament. Okay, this is the superior border. Next, coming to the medial side, so the ligament is by the adductor longus. Okay, this is the medial ligament, and on the lateral side the ligament that will be formed by the sartorius. Okay, this is the lateral border of the femoral triangle. Again, what is the important content that is present in the femoral triangle? So the content here present is the femoral vessels. Okay, so both femoral artery and a vein, and along with that there is a femoral nerve which is also present here. Next, the branch genitofemoral nerve also present in this particular region. Okay, here you can see common femoral vein and also common femoral artery and femoral nerve. Along with that, the other artery that will be present here, other nerve that is present here is the femoral branch of the genitofemoral nerve. And along with that, there is a content here, the femoral canal. In the femoral canal, you are also going to present with the lymph nodes is also present. Okay. Next, moving on to the popliteal fossa. What are the contents that is present in the popliteal fossa? The nerves that you have to remember. Borders is easy to remember guys. See, this is the upper version, right? This is the superior and this is the inferior. So in the inferior region, both sides, here you can see this is the medial head of the gastrocnemius and this is the lateral head of the gastrocnemius, right? In the inferior side you can easily identify, but on the superior side you have the two different types of the muscles that will be surrounding. So one is the semi-membranous and other one is the biceps femoris. These both are going to be from the medial and the lateral. Next, coming to the content. So in the important content that is present in the femoral fossa is, there are the two important nerves that you have to remember. First, it is sciatic nerve that is also passing here, and next there is a tibial nerve which is also bifurcating from here. So the tibial nerve, sciatic nerve, and also common fibular nerve and popliteal artery and the popliteal vein. So both popliteal veins which also be present here in the popliteal fossa. Okay, so what are the nerves guys? Sciatic nerve, tibial nerve, and common fibular nerve, and both the popliteal artery and the popliteal vein is also present in this particular location, right? These are the important points that you have to take note, and what is the content that is present here. Next, moving on to the picture, this is the question that has been asked in the examination guys. Understand, from this picture you have to identify this. So this is on the thumb, this is your thumb and this is your little finger, right? So these are the tendons that you have to label. Okay, so these labeling you have to do not make the mistakes. So these labeling you have to understand. On the little finger, that is belongs to the flexor carpi ulnaris. Okay, this is flexor carpi ulnaris, and here this picture is belongs to the flexor carpi radialis. Flexor carpi radialis, that is present, and this middle one is the palmar longus. Okay, this is belongs to the palmar longus tendon. Okay, this is flexor carpi ulnaris tendon. This is the flexor carpi radialis tendon, and this is the palmaris longus tendon. Okay, right. Next, moving on to the another picture. Here you can see this is the anatomical snuff box. In the anatomical snuff box, if there is a pain, in the anatomical snuff box, this is due to scaphoid fracture. This is due to scaphoid fracture most commonly. Next, coming to the content, what is the artery that is passing here? The radial artery is going to be passed from the anatomical snuff box. Next, what about the borders, guys? So in the anatomical snuff box, if this is your anatomical snuff box, so there is a two tendons that is present in the inferior side. Okay, so what are those two tendons? Those are your tendons extensor pollicis brevis and abductor pollicis longus. Okay, so this one is your abductor pollicis longus. Okay, and this one is your extensor pollicis brevis. And what about the superior one? This is the extensor pollicis longus. Okay, here this is extensor pollicis longus, and again content is the radial artery that will be passing here, and also radial nerve. Okay, radial nerve is also passing. If there is a fracture from the scaphoid bone, that will be painful. Next, moving on to the Hesselbach triangle. Here you can see this is the Hesselbach triangle. So in the Hesselbach triangle, guys, you have to remember one thing. What are the content? Okay, how it is going to be differentiated. So in the Hesselbach triangle, this is your Hesselbach triangle. All right. So in the Hesselbach triangle, so this is the medial. Okay, this is the medial border, which will be rectus abdominis muscle. Okay, and here this is the inferior, right? So in the inferior, this one is known as your inguinal ligament. Okay, I for inferior and I for inguinal ligament. Okay, this is inferior border, right? Next, on to the lateral side. So this is the lateral side, right? In the lateral side, you are going to have the inferior epigastric vessels. Okay, this is the lateral side of the vessels. Okay, this is the content. This is the triangle borders. Next, moving on to the another picture here. This is the Calot's triangle and this is the hepatocystic triangle. So coming to the Calot's triangle, what is the importance of the Calot's triangle, guys? This is important for when you are going to proceed for the cholecystectomy. Okay, especially laparoscopic or the open cholecystectomy, this is going to be important. So here you can see this border is going to differentiate it. How? In the Calot's triangle, here on the other side, like medial side, there is a common hepatic duct. Okay, this is the common hepatic duct, and this side, on the lateral side, you are going to have the cystic duct. Yeah, this is the cystic duct. And how about the superior side? On the superior, this is the one passing, right? So this is known as a cystic artery. This is known as a cystic artery, which will be forming the superior side. Next, hepatocystic triangle. In the hepatocystic triangle, the superior one, which will be by the inferior, this is by inferior border of liver, inferior border of the liver, and medial, again same content, common hepatic duct. On the lateral side, cystic duct. Only the differentiation between this one is Calot's triangle superior is the cystic artery and hepatocystic triangle is the inferior border of the liver. Next, moving on to the pulse points, guys. First, importantly, you have to identify this pulse points by the picture itself. Okay. So here on the forehead, this is the temporal artery. On the cheek, this is the facial artery, and on your anterior triangle, this is the carotid artery, and on the brachial cubital fossa, this is the brachial artery. At the radial, again anatomical snuff box, this is the radial artery, and femoral artery in the inguinal region, and popliteal artery back of your popliteal fossa, posterior tibial artery on the shin, and foot you are going to see this is the dorsalis pedis artery. Okay, these are the pulse points can be asked in the examination. Next, moving on to the pharyngeal derivatives. So we all know that pharyngeal derivatives is going to give rise difference of the structures. How the pharyngeal derivatives are going to develop, guys? This is the way. Okay, here you can see this is how the all the structures, cartilages, muscles, bones, and arteries and nerves are going to be covered. Okay, even though if you are confused with this one, you have to remember the facial structures. Okay, so the first one which will be starting here, second one will be here, third, fourth, fifth, and sixth. Okay, until here you are going to end. At least by that structure also you can recall this one. So first, from the pharyngeal first arch, what are the contents? At least remember these important points, guys. First, in the from first one, you are going to have the mandibular artery and maxillary nerve. Okay, don't confuse between these two. Maxillary nerve. Next, second arch. From the second arch, it is going to be stapedial artery. This is the stapedial artery and facial nerve. Okay, this is the facial nerve that is going to be come from the second one. Next, third arch. In the third arch, this is by glossopharyngeal nerve. This is by glossopharyngeal nerve and carotid artery. A carotid artery which will be coming from here. Next, fourth arch. This is your fourth arch. So from the fourth arch, there will be arch of aorta, arch of aorta, and superficial laryngeal nerve. Okay, superficial laryngeal nerve which will be transmitting here. Next, this is the sixth one. Okay, so fifth one is not seen here, only sixth one will be seen. So from the sixth, recurrent laryngeal nerve. And coming to the arteries, it is going to give the ductus arteriosus. This is the PYQ, guys. Ductus arteriosus and right and left pulmonary arteries. Right and left pulmonary arteries which will be coming from this pharyngeal derivatives and the arches. Okay, so same that is given here also. What are the nerves that is going to be coming from here? Next, another thing that you have to remember here, what are the muscles and what are the structures? Just yesterday we discussed what are the derivatives that has been derived from the structures that you have to remember. At least if you don't have to remember all the structures, but remember this nerve and artery from this pharyngeal derivatives. Next, coming to the JVP. In the JVP, you have to take note of these important points, guys. Especially see, this is how we are going to calculate the normal JVP. How we are going to check the JVP, guys? This is the position. You are going to place the patient on the supine 45 degrees, and then you are going to place the scale and measure this jugular venous pressure. And all the jugular venous pressure is especially coming from the first atria, right atrium. You are going to get this. How the waves are formed? When there is an increased pressure, you are going to see increased pressure, the A wave is formed. What is meant by the A wave? Atrial contraction. And once the atrial contraction is done, it is going to relax, right? The pressure is going to drop. This is atrial relaxation, which is seen as a X naught. And next, again, there is a sudden pressure. Why this sudden pressure? Because the tricuspid valve, which is closed, and here the ventricular contraction, this pressure is high, so that the tricuspid bulge is seen in the right atrium. Again, there is a C wave that is formed. Then again, there will be a passive atrial filling, right? Once the valves is open, this is going to fill. This is the X naught we are going to see. Okay, this is the systolic phase. And again, after that, there will be maximum atrial filling. How the atria will be filled? From the carotid cardiac vein, from the inferior vena cava, superior vena cava, all the filling will be coming. So once it reaches the maximum filling, the pressure will be rising. So that will be seen as a V wave. And once again the tricuspid valve is open, again the atria is going to empty into the ventricular filling, right? Atria emptying, that nothing but ventricular filling, right? Ventricular filling, which will be seen as a Y wave. But they are the pathologies, that is pathology that will be associated with this graph. So if the JVP findings, if you see there is a absent A wave, if there is a absent A wave seen in the atrial fibrillation, okay, and Canon A waves. What is mean by the Canon A waves? These are seen for the C for Canon, C for the complete heart block. Seen in the complete heart block you are going to see. Next, X descent. If the X descent is prominent, if the X descent is prominent, this is seen in the constrictive pericarditis. This is seen in the constrictive pericarditis. Next, if the Y descent is absent, Y descent is absent, this is seen in the cardiac tamponade. Emergency condition, cardiac tamponade, you are going to see this condition, right? Next, giant A wave. There is a giant A wave. This is tricuspid atresia. Tricuspid stenosis. Right, these are the some conditions associated with the JVP, and this is how we are going to interpret. Right, next, moving on to the hypothalamus areas. In the hypothalamus areas, commonly asked questions from which of the nuclei. Okay, there are the many nuclei here. You can see preoptic, paraventricular, posterior, ventromedial, mammillary bodies, supraoptic, suprachiasmatic. But at least remember these. First, hypothalamus, which will be important for the temperature, right? So in that temperature, it is divided as a anterior nuclei and the posterior nuclei. So from the anterior nuclei, you are going to get the heat, okay? And from the posterior, it is going to be cold. Okay, this is going to be cold. Next, coming to the another important one, circadian rhythms. So this is the suprachiasmatic. Circadian rhythm is from the suprachiasmatic. Right, next, supraoptic. Supraoptic is for the ADH hormone. Okay, antidiuretic hormone. Next, paraventricular. Paraventricular is important for the oxytocin, guys. Next, mammillary bodies. Okay, mammillary for M for mammillary, M for memory. Next, ventrolateral. Ventrolateral. This is for the sleep. Next, ventromedial. Ventromedial. So medial. This is for the food satiety. Okay, this is how you have to remember, guys. Ventrolateral. Once you are done, you are going to sleep on the other side. When you are hungry, you are going to come into the middle. That is the satiety. Paraventricular, oxytocin, mammillary, M for memory, supraoptic ADH, suprachiasmatic, circadian rhythm. Okay, these are the nuclei. That is very important. Next, moving on to the oncogenes. What are the important? So RAS-K is for the colon cancer and the pancreatic carcinoma. RAS-H for the renal cell carcinoma, pituitary carcinoma. RAS-N, M here N, that is the melanoma. ABL is for the CML. BRAF gene for the hairy cell leukemia. MIXI gene is for the Burkitt's B and C, and N for N, neuroblastoma. L for L, lung cancer. Cyclin D for the mantle zone lymphoma. PDGF is for the osteocytoma. FGF, fibrosarcoma. HGF, hepatocellular carcinoma. PDGFR for the glioma. EGFR, that is for the adenocarcinoma. EGFR2 for the breast cancer, and red gene is for the men syndrome 2A and 2B. Kit for the, what are the kit that is include? Just AML, melanoma and seminoma. ALK is for the adenocarcinoma of the lungs. CDK4 is for the glioblastoma. Next, tumor suppressor gene. What is the most common one? That is the P53. Present in the 17p chromosome. Lee-Fraumeni syndrome will be seen. So, multiple tumors will be affected in this patient. RB gene is for the retinoblastoma 13q. NF1 17q for the neuroblastoma patients. NF2 22q, that is the schwannoma. BRCA1, BRCA2 17q and the 13q respectively, breast carcinoma. And WT1, which will be associated with the 11p, WTT also 11p, Wilms tumor. VHL, Whipple syndrome, this is the, and 3p is for the renal cell carcinoma. Right, next, coming to the tumor markers. Calcitonin is for the medullary carcinoma of the thyroid, and AFP is for the hepatocellular carcinoma, yolk sac tumor, beta HCG for the germ cell tumor, and also choriocarcinoma. Choriocarcinoma. right? Next, PSA for the prostate carcinoma, catecholamines pheochromocytoma, CEA for the colon carcinoma and the pancreatic, CA72 stomach cancer, CA19 for the colon, better CEA choose the colon, CA19 better choose the pancreatic, CA15 breast carcinoma, CA125 ovarian carcinoma, and TG thyroglobin for the papillary thyroid carcinoma and also follicular thyroid carcinoma. Okay, these are the important tumor markers that you have to remember. Next, moving on to the urethral trauma. So urethral trauma is subdivided, guys. One is the bulbar urethra injury and other one is the membranous urethra injury. So here you can see where is the most common site for the bulbar urethra. Bulbar urethra, guys. Here you can see this is the breakage that is happened bulbar urethra where the urine is going to standard here. So basically here you can see bulbar urethra is ruptured. So Buck's fascia whichever is covering here also going to rupture. So the urine will be leaked here into the scrotum, right? And also what happens that will be leaking here also and the backside of the deep penile and also here there will be a supraperitoneal pouch. Here also that urine is going to stagnate. Next, this here you can see another picture. This is the membranous urethra or posterior urethral injury here. So it is very far from the scrotum. So no scrotal hematoma will be seen in this patient. Deep peroneal pouch which will be coming to the and deep peroneal pouch here you can see and also the space there will be high rating towards the prostate. Okay, but remember that these is not going to come into the peritoneum. Okay, that is the first thing. There is no peritonitis will be seen in this patient unless or until if there is a bladder injury, there will be there will be contaminated peritoneum will be seen. But only regarding in the pelvic structures only we are going to see the urethral injury. Next, moving on to the chest trauma. So in the chest trauma, you have to understand, guys, these are the some of the important topics. Okay, first here you can see this is the pneumothorax. Okay, this is the pneumothorax. And coming to this picture, this is the hemothorax. This is the hemothorax. Next, this is the flail chest. This is the flail chest with the multiple rib fractures and this is the cardiac tamponade. Okay, first we have to understand what is the treatment protocol that we have to follow for these patients. If you see this particular structure, particular symptoms in the trauma cases. Okay, first we will finish the cardiac tamponade and then we will see the difference of these particular things. Okay, first moving on to the cardiac tamponade. What is the most common cause, guys? In the most common cause for the patients those who are suffered with the cardiac tamponade is the trauma. Okay, so how the cardiac tamponade is formed? So for example, this is how the heart, right, silhouette will be seen, but this is the covering of the peritoneum. So what happens when there is a peritoneum which will be filled with the blood? What it is going to do, it is going to push more hardly, the pressure will be increased into the heart, so the heart will be compressed. Okay, heart pressure will be compressed more, so the patient will be having the symptoms of Beck's triad. What is mean by the Beck's triad? The patient will be experiencing the hypotension because this pressure is happening that the aorta cannot overload, right? So hypotension. And heart sounds you cannot use because see the swelling. Okay, so the muffled heart sounds will be seen and JVP pressure will be raised. JVP pressure will be raised. Along with that, what I said, guys, wide descent will be absent. Okay, and there will be paradoxical pulse will be also seen in this patient. This is the cardiac tamponade. What is the immediate treatment? Cardiac tamponade means pericardiocentesis. You can do at the xiphoid. Here there will be a xiphoid process. You can insert the needle and you have to remove the pressure. That is how we are going to proceed for this patient. Okay. Next, moving on to the pneumothorax. Pneumothorax is very important topic, especially where is the location that we are going to place for this patient. Okay, and in pneumothorax patient also how they are going to present, guys. Basically common things. The patient will be having the breathlessness, and patient will be having the experiencing the JVP will be raised. Why the JVP will be raised in this patient? Because if you observe why the JVP will be raised, because the pressure that is coming here, okay, the pressure will be compressing, the air will be going to compress, and which will be causing the pneumothorax, okay. And the most common cause will be tension pneumothorax, and tension pneumothorax will be either it could be by the stab injury, or suddenly there will be injury of the trauma related to the RTA causes, okay. And how we are going to identify this particular patient, those who are suffering from the pneumothorax? On the X-ray, you are going to see the collapsed lung and lack of lung markings. So the lung markings will be absent here. Okay, lung markings will be absent. And if it is severely affected, you are going to see the tracheal shift to the opposite side. That is also seen in this patient. Next, how you are going to identify by the symptoms? Okay, basically the symptoms will be increased respiratory rate, decreased cardiac output, and patient will be having the decreased BP, increased tachycardia will be seen in this patient. Okay, as I said, JVP will be also raised. Next, on the treatment, on the emergency treatment for this patient, for the adults, needle will be inserted at the which location, guys? Fifth intercostal space in the mid axillary line. Okay, mid axillary line you have to insert. Next, but you have to now understand that it should be at the anterior axillary line instead of the mid axillary line. Better choose the anterior axillary line. Next, coming to the children, it has to be at the second intercostal space at the mid clavicular line. Okay, mid clavicular line, guys. Okay, this is the mid clavicular line. Okay, for the adults, needle should be inserted fifth intercostal space anterior axillary line. Children, second intercostal space mid clavicular line. And after that, after the needle compression, you have to move for the tube insertion. Okay, tube thoracocentesis should be given, and this tube should be at the location of the triangle of safety. Okay, triangle of safety up to inside. Right, next, here the another picture. This is the hemothorax. Hemothorax means, hemo means blood. The blood is accumulated in this patient. How the patient is suddenly there are the vessels which will be presenting here, right? If their vessels are ruptured, that is going to cause the hemothorax in this patient. So on the percussion, the main difference between the hemothorax, you are going to listen to the dull. Okay, so the dull note, if you see, that is the hemothorax. If you don't see the dullness, that is the pneumothorax, right? And treatment for this patient is the chest tube drainage. Okay, chest tube insertion, and after that you are going to drain that fluid from this here. And specifically the air fluid level, you are going to differentiate air fluid level that will be present here, right? That is how we are going to do for this patient. Next, coming to the failed chest, here you can see this is the failed chest. Here you can see the refracture. So the failed chest means, what is the important here? If they are more than two ribs are fractured, if they are more than two ribs are fractured, then we are going to consider this as a failed chest. Along with that, the patient will be having the contusion. Okay, contusion to the chest region, and also contusion to the lungs, which will be most common cause of the death for this patient. And clinical features, there will be paradoxical chest movement. Paradoxical chest movement will be seen in this patient. Okay, and treatment of the choice for this patient is O2 and also analgesia as needed, and we can go for the intermittent positive pressure ventilation as soon as possible before we proceed to the surgical fixation for this patient. Okay, next we are going to discuss about the gout and the importance of the gout therapy. So first, gout is divided into the two types case. One is the acute, another one is the chronic, and the gout is unrelated, which is known as a pseudo gout. Let's see first, acute gout patients which will be presenting the pain in the podagra. Okay, where is this podagra region will be seen? The first metatarsal joint, right? First metatarsal joint, the pain will be highly seen in this patient. Next, the patient, those who are suffering from the chronic gout, it is commonly seen in the knee region. And in the patient, those who are suffering from the pseudo-gout also knee region only. And here uric acid levels will be normal, and here also uric acid levels will be highly increased because it is already chronic condition. Next, in the patients, those who are suffering from the pseudo-gout, here it is also normal. Why it is normal? Because the name itself telling it is pseudo-gout, not related to the gout. Next, what are the crystals that is increasing in the gout and the pseudo-gout? In the gout people, the common one is the hyperuricemia. The monosodium hyperurate crystals are increasing in this patient. The pseudo-gout patient, it is due to calcium pyrophosphate. Okay, this is due to calcium pyrophosphate. On the histology, the needle-shaped negative birefringence you are going to see. Okay, this kind of needle-shaped you are going to see. Pseudo-gout, you are going to see this rhomboid-shaped positive birefringence will be seen in this patient. Next, coming to the treatment. Basically, in the patients of the acute gout, we can give the NSAIDs because the uric acid levels is still normal only. So for that patients, we are going to proceed for the NSAIDs, and the best drug we can give this patient is the endomethacin. And if it is not treated, then we can add the colchicine. Okay, this is going to be anti-inflammatory. Next, those who are suffering from the chronic gout, for this patient, you have to give the allopurinol. So what is the mechanism of the allopurinol, guys? This is going to inhibit the purine metabolism, that the xanthine oxidase inhibitor. This is xanthine oxidase inhibitor. So if actually this has the determinant effect, so nowadays we are going to add the febuxostat. Okay, but the drug of the choice is still allopurinol only. For the patients of the pseudo-gout, same, this is the not related to the uric acid. So NSAIDs is the first line of the therapy. Next, we will see what are the other drugs in the urea. Okay, first uric acid. Okay, first, what are the drugs that is going to increase the uric acid? First, you have to take note. Diuretics. Okay, especially the loops and also thiazides. This is going to increase. Next, coming to the any other drugs that is going to increase, guys, TB therapy. Okay, the TB therapy drugs like ethambutol, pyrazinamide also going to increase. Next, niacin. So niacin can also increase the patients with the nicotinic acid will increase the uric acid levels in the body. Next, low dose aspirin. Okay, low dose aspirin can be also increase the patient with the uric acid. Next, methotrexate, okay, cyclosporine. These drugs are going to increase the uric acid. Next, we have the uric acid classification, how these drugs are going to decrease. So first example, we have seen xanthine oxidase, allopurinol and the febuxostat. Next, uricosuric. So these drugs is going to excrete the uric acid from the urine. Excrete the uric acid from urine. So this is like a elimination from the body. What are those examples, guys? Propenicid, okay, propenicid, and also lesinuride. These are the drugs going to excrete the urine from our body through the urine, right? Next, another one, uricase analogs. Uricase analogs. So uricase analogs going to be like rasburicase, and pegloticase. These are the drugs, uricase analogs, which will be seen. Next, some of the other classification drugs can also decrease. Example, high dose aspirin. So aspirin have two properties. Okay, aspirin have many properties actually. If you see at the low dose, it is actually increasing the uric acid. But when again you are giving the high dose, it is going to convert it into the low dose of the low of the uric acid. And same like that, at the low dose, it is going to act as a antiplatelet, and at the high dose, it is going to act as a anti-inflammatory. So aspirin can work in the different ways in our body. Next, tumor lysis syndrome. For this tumor lysis syndrome, for this patient, we can give the rasiburicase. For the chronic gout, allopurinol can be given, and some other drug also you have to remember, guys, losartan. Okay, losartan can also decrease the uric acid. It acts as a decreasing the uric acid for the patient. Right, these are the some of the important drugs that you have to remember for the gout therapy. Next, moving on to the migraine and therapy. So in the migraine and therapy, you have seen many drugs, right? So basically, we are going to give this patient sumatriptans. This triptans is going to help those patients. But there is an important classification for the migraine that you have to take note, guys. First, in the you have to understand how the migraine will be affected in this patient. What is the characteristic feature of the migraine? The patient will be having the pulsatile pain, and which will be associated with the, specifically the pain will be associated with the aura. Okay, aura means the patient will be having the nausea, vomiting, photophobia will be seen, and the headache is which is associated with this one is the classical, but most commonly non-classical is the common. This is the non-classical presentation is the most common. Pain will be pulsatile. Pulsatile pain will be seen in this patient. Next, coming to the treatment, drug of the choice. Basically the drug of the choice will be triptans. Triptans will be given for this patient, right? Sumatriptan. These triptans are actually not given for the patients. Okay, it is going to cause the vasoconstriction. For that, why it is contraindicated in the patients of the pregnancy. Okay, so in the pregnancy also the first trimester is contraindicated. Second and third you can give the sumatriptans. And ischemic heart disease and also cardiovascular, and patients those who are suffering from the cerebral vascular accidents. Okay, this is the cardiac disease CAD, and this is the CVA. These patients are contraindicated for these drugs. And other drugs we can give the ergot alkaloids and other drugs. Okay, but we have to, prophylaxis has to be started for this patient. Prophylaxis. So for the prophylaxis, the drug of the choice is the beta blockers. Most commonly, we are going to give the propranolol. Other than that, topiramate. Topiramate can be given. So this will help the weight loss for this patient. And calcium channel blockers such as verapamil and also amitriptyline, anti-depressant, right? Amitriptyline can be given, and also, for example, you can give the monoclonal antibodies nowadays, eru, erunimab, and Glaca. Remember, like girls are most affected with the migraine. Okay, Glaca nizumab can be also given for this patient, and toxins such as botulinum toxin can be also given. These are the drugs that we are going to give for the patients those who are suffering from the migraine. Next, cluster headache. Last year asked question for this patient. O2 therapy is given, guys. Okay, and those who are suffering from the tension headache patient, NSAIDs is the first line of therapy that we are going to give this patient. Okay, next, then coming to the other types, for example, prophylaxis for this patient, anti-steroids. Okay, steroids is given for this patient as a prophylaxis. Next, for this patient, those who are suffering from the tension headache, you have to give this patient antidepressants. Okay, antidepressants should be given. Prophylaxis. Right, this is for the headaches, migraine, and their therapy. Next, coming to the epilepsy, guys. In the epilepsy also, where there are the many important types, right? You are going to have the benzodiazepines, which will be commonly used, but this commonly asked question specifically which type of the seizures. Okay, coming to the children, anti-epileptics is most commonly used in the febrile seizure. Okay, so for the patient, those who are suffering from the febrile seizure, what is the drug of the choice for this patient? Okay, for this patient, we are going to give the lorazepam or diazepam is the first line of the therapy that we are going to give for this patient. And those who are suffering from the general tonic-clonic seizure, or those who are suffering from the myoclonic jerks, this is the juvenile seizures, or those who are suffering from the Lennox-Gastaut syndrome, or those who are suffering from the Dravet syndrome, all this patient, the sodium valproate is given. For this patient, sodium valproate is given. For those who are suffering from the neonatal seizures, okay, neonatal seizures less than 28 days, for this patient, phenobarbital is given. Phenobarbital is given for this patient. And if you see the patient with the status epilepticus, for this patient, first you are going to give the lorazepam. Then if it is still not working, then we are going to proceed for the phenytoin. Okay, phenytoin is given for this patient. Next, infantile spasms. Okay, infantile infantile spasm patient, we are going to give who is suffering from the tuberous sclerosis. For this patient, vigabatrin is given. Okay, vigabatrin is given. Those who are suffering from the West syndrome, ACTH is given for this patient. And eclampsia patients, for this patient, IV MgSO4 is given for this patient. Next, coming to the pregnancy patient. In the pregnancy patient, what is the best drug that we can start, guys? Levetiracetam. Levetiracetam is given no history, if no history of other drug. But the patient is already on the valporate, then continue, right? Then it can be continued. Next, we forgot the another important one, that is absence seizure. Okay, for the patient who is suffering from the absence also, we are going to give the sodium valproate. Next, in the antiplatelets only, I want you guys to know about the side effects that will be associated. Okay, for example, phenytoin. For the phenytoin, the most commonly this patient is suffering from the difference of the side effects. Let's see what are those side effects. The phenytoin is going to be 450 inducer. It is going to be 450 inducer, and it can cause the hirstism in the patient, and gingival hyperplasia will be seen in this patient, and it can be severe teratogen. Okay, this can be severe teratogen, and patient will be having the nystagmus will be seen, neuropathy will be seen, and anemia will be seen in this patient. Why anemia will be caused, guys? Because it is going to decrease the folate. So if it is a decrease the folate, it can also cause the neural tubal defects in the patient, right? These are the some of the side effects associated with the phenytoin. Next, moving on to the audiology. In the audiology, you have to take note Carhart notch. So where this patients, when you do the Carhart notch, where you are going to see the Carhart notch, guys? Basically, it is at the 2000 hertz. Okay, at the 2000 hertz, if you see the Carhart notch, this is seen in the otosclerosis. This is seen in the patients of the otosclerosis. If you see the 4000 dip, if you see the 4000 hertz dip, this is seen in the patients of the noise induced. This is induced in the noise induced hearing loss. Okay, next here, rising. Okay, this rising is seen in the patients of the Meniere's disease. Next here, down the slope will be seen. This is seen in the presbycusis patient. Next here, this is the last year asked question, guys. What is this one? This is the tympanometry. So for the patient, those who are suffering from the tympanometry defects, what is the normal that you have to understand? So the type A, this is the normal range, which will be known as a type A. Okay, type A is normal. Okay, next, type AS is due to ossicles, so otosclerosis condition. Next, AD is due to ossicular dysfunction. Okay, this is due to ossicular dysfunction or dislocation. Okay, next, type B. Type B is due to middle ear. Okay, middle ear, which will be condition is known as a glue ear, right? Effusion is filled with the completely cerumen or the effusion. Next, type C, ET dysfunction, right? These are the some of the types, and the AD is for the ossicular dislocation, C is for the eustachian tube dysfunction, B is for the glue ear, and AD is for the AS is for the otosclerosis. Okay, next, larynx disorders. So in the larynx disorders, guys, here you can see some of the important types: the vocal nodules, vocal polyps, intracaudal cyst, Rinck's edema, laryngeal carcinoma, and also glottic sulcus and laryngeal keratosis, laryngomalacia. Right? These are the things that we have seen here. First, we are going to see one by one. What are the important factors that you have to understand? First, vocal polyps. Okay, vocal cord polyp. So, vocal cord polyps. What is the most common location for the vocal cord polyps, guys? The vocal cord polyps. The common location for this patient is 1/3 of this is seen here. You can see vocal cord polyps are usually unilateral. So the tension will be 1/3 of anterior and 2/3 of posterior. And this is unilateral side ocal polyps. Seen in which patients? Most commonly this is seen in the patients of the teachers. Okay, teachers. These patients you are going to see. Next, ocal cord nodules. Same location, 1/3 of the anterior, 2/3 of the posterior. But it is bilateral. Okay, always it can be bilateral. Same again, teachers, fingers. Okay, this patient you are going to see. And what is the difference treatment that you are going to give for this patient? So for the ocal cord polyps, you have to do the laser surgery. Microscopic laser surgery should be done. For this patient, the rest is important. The treatment is simply rest is important for this patient. Okay. Next, Rinke's edema. Next, knowing to be Rinke's edema. This is seen in the smokers. This is seen in the smoker. Here you can see this is the Rinke's edema. Okay. Just very subepithelial space. There is a space between the ocal cords. So in that ocal cords, the Rinke space is known, and in that space there will be edema. Okay. For this patient, what we have to do? Stripping of mucosa. The treatment will be stripping of mucosa that you have to see. And this Rinke's edema is seen in the bilateral location. Okay. Dysphonia. Common symptoms all for this patient is the dysphonia only. Next, this condition, guys, this is known as a laryngomalacia. Right, this is known as a laryngomalacia. In the patients those who are suffering from the laryngomalacia, what happened? The commonly this is a congenital condition. This is a congenital condition. In the patients of the congenital condition, this is can be treated. How is it? The surgery or the conservative? Most commonly this is treated as a conservative. Why? Because this laryngomalacia is a defect by the birth only, but it is going to settle by the 16 to 18 months. So for that the reason we are going to treat this as a conservative management only. Okay, and the patient will be presented with the stridor. This is the first difficulty. Sorry, easy to understand as if the stridor is present in the patient, then yes, this is the most likely associated with the patients those who are suffering from the laryngomalacia. Okay, and what is this sign you are going to see? This sign is known as a omega shape. Omega shape, omega shape of the laryngomalacia. This structure larynx will be seen in this patient. Okay, assurance is the important to treat for this patient. Next, laryngeal carcinoma. Here you can see the laryngeal carcinoma that we are going to discuss now. In laryngeal carcinoma staging, guys, first you have to remember the staging, how you are going to stage for this patient. Basically there will be TNM staging only. Here also we are going to follow the TNM staging. So in the TNM staging, they are the structures that you have to remember. Okay, the TNM staging, first T1 is for the one structure only involved. Okay, only the one structure involved. Next, T2, more than one structure involved. And here T3, the ocal cords is completely involved and fixed. The cancer is fixed to the ocal cords, only inner. And T4 is beyond larynx. Beyond the larynx, and even the thyroid cartilage is also involved in this patient. That is the staging for the thyroid carcinoma of the TNM staging that you have to understand. Okay. Next, these are the important factors that you have to remember. For example, if you see the granuloma, this is associated with the HPV 6 and 11 oral type of the cancers. Okay, laryngeal keratosis, this is also due to smoking. Most commonly, this is due to smoking. The outer layer that will be damaged due to the keratosis. So, bilateral ocal cord nodules, polyps is a unilateral. These are the cyst, very cystic, that will be structured with the some type of the fluid will be the leaking of the fluid will be edimated here in the intracaudal cyst. Next, moving on to the ocal cord nerve palsy. You have to understand this ocal cord nerve palsy. There are the two types of the ocal cord nerve palsy, guys. One is the abductor palsy, other one is the adductor palsy. So first we are going to see the abductor palsy. Okay, bilateral abductor palsy. Abductor palsy What does it mean? That means the patient cannot go to the abduction. So the vocal cords will be seen this way only. The both are going to together. This is how you are going to see the larynx. The larynx are in the adduction position. Adduction is normal in this patient. So what are the symptoms that is going to be presented in this patient? There will be respiratory distress, right? There will be respiratory distress, right? If it is cannot be opened, the patient will be having the respiratory distress. So what is the most common, the nerve that is involved in this patient, guys? The nerve that is involved here is the bilateral recurrent laryngeal nerve. Recurrent laryngeal nerve that is involved in this patient. Okay, the treatment, immediate intubation. So better than the intubation, we cannot insert the intubation tube, right? So better go for the tracheostomy. So after the 6 months, you can go for the thyroplasty. So this thyroplasty is type 2. Type 2 thyroplasty should be done for this patient. Next, bilateral adductor palsy. Bilateral adductor palsy. On the bilateral adductor palsy, this is the vocal cords, right? So this is how it is going to be seen. So adduction is normal in this patient. Sorry, abduction is normal in this patient. Abduction is normal in this patient. So the symptoms, how it is going to be presented? No voice. He cannot hear the phonation, but respiration is normal. So if it is completely open, there is a risk of aspiration, right? This is also seen in this patient. So the treatment is type 1 thyroplasty. Type 1 thyroplasty should be done for this patient. Okay. Next, adductor palsy. What is the nerve that is involved here, guys? The both nerves are going to be involved here. Okay. Recurrent laryngeal nerve and also superior laryngeal nerve. This both nerves are going to be involved in this patient. Okay. That is why this is known as a adductor palsy. Okay. This is the difference between the vocal cord nerve supply and the palsy. Okay. Now I haven't discussed about the what are the nerves that is going to be what is the nerve supply here, right? First, remember how the nerve supply will be seen in this patient. Okay, the three different structures, right? We have the supraglottis, glottis, and subglottis, right? So, for the patient, for the normal patient, the supraglottis is supplied by the inferior laryngeal nerve. It is supplied by the inferior laryngeal nerve. And next, glottis. So this glottis is going to be supplied by the superior laryngeal nerve and also inferior laryngeal nerve. And subglottis is supplied by the recurrent laryngeal nerve. Okay. And glottis will also have the recurrent laryngeal nerve. So all these nerves will be supplied by this structure. Supraglottis. Let's also understand normal nerve supply. Okay, first you have to understand all the larynx muscles are supplied by the recurrent laryngeal nerve. Okay, except circothyroid. So except circothyroid, then what is the supply for the circothyroid? It is supplied by the external superior laryngeal nerve. External superior laryngeal nerve, it is supplied. Okay, next coming to the glottis structures. Okay, the supraglottis is supplied by the internal, it is going to supplied by the internal superior laryngeal nerve. Next, glottis is supplied by the external superior laryngeal nerve and also internal superior laryngeal nerve. Subglottis is supplied by the recurrent laryngeal nerve. Okay, it is supplied by the recurrent laryngeal nerve. Okay, this is how you have to remember this nerve supply for this vocal cords. Okay, next moving on to the hepatitis markers. So hepatitis markers, guys, this is a very common topic. Just interpretation can be asked in the examination. Okay, so let's see. First, how the transmission will be seen after the 180 days. Okay, nearly 60 to 80 days, the transmission will be seen in this patient. Okay, what are the first antigens will be developed? Let's see here. the first antigen to appear in our blood after we get the hepatitis infection, that is HBsAg. HBsAg is the first is going to develop. So this is the acute infection. Okay. Next, HBeAg, which will be presented second, and this will comprise as a acute infection with high infectivity. This is going to be high infectivity and high replicity will be seen with this. Next, antibodies. So in the antibodies, you are going to see what is the first antibody that will be present in this patient, guys. Anti-HBs, anti-HBC antibodies. So IgM acute, IgG is going to be chronic. Next, anti-HBe antibodies. That means the infection is decreased. This is chronic and low infectivity. Low infectivity, low replicity will be seen. Okay. Next, anti-HBC antibodies. That means already the patient are cured or likely to be the patient is vaccinated. These are how antibodies are the antigens will be seen. So in the entire pathway of our life with the years of infection, the only agent is going to be active throughout is the HBsAg. This is going to be active throughout the period. Regardless of the window period, acute infection or the chronic, HBsAg is going to be positive for the lifelong of the patient. Okay, that is the first thing. Next, interpretation coming to here, the patient those who are suffering from the acute, the HBC antibody IgM will be positive, HBsAg will be positive, and also in the acute time HBeAg will be positive. Next, coming to the chronic, you are going to see HBcAbG antibodies and also HBsAg, and sometimes HBeAg will be positive or the not. Next, anti-HBe will be positive for this patient. Okay. Next, cleared HBV, still you are going to see this one. Okay. You have to correct here. HBsAg will be seen in this patient. Anti-HBs is positive and HBC antibodies is also positive. Okay. Vaccinated anti-HBs is nothing but anti-HBC antibodies is going to be seen as a cured or vaccinated patients. Next, moving on to the tuberculosis. First, let's see the differences in the tuberculosis. Those who are suffering from the tuberculosis, how this is transmitted, guys. Most commonly, the patient will be transmitted by the droplets. After that, here you can see this is the lymphadenopathy will be seen in this patient. So the bilateral hilar lymphadenopathy will be seen in this patient. Along with that, there will be foci that will be seen together, which will be called as a Ghon complex. This is the latent TB and known as a miliary TB. Okay, latent and again reactivation known as a miliary or the disseminated TB. This is what is this, guys? LJ medium, right? Lower strain Jensen medium. You are going to this medium has to be cultured for the tuberculosis. Okay. Next, what are the symptoms? Commonly, the patient will be having the low grade fever in the evenings, weight loss, sputum production, will be seen, and also night sweats. These are the common symptoms will be seen in this patient. And if you do the histopathology, you are going to see the caseous necrosis. Okay, cheesy necrosis will be seen in this patient. Next, coming to the treatment, you are going to give the treatment for the 6 months. Okay, it is one is the intensive. In the intensive, it is going to be 2 months, and then continuous treatment will be given for the 4 months. Total 6 months we are going to give. What are the drugs? Rifampicin, which will be inhibiting the DNA dependent and the RNA polymerase. And the side effects, orange body fluids, hepatotoxicity will be seen. Next, another key point, it is going to be CY50 450 inducer also. So that's why if you take with the OCP or the warfarin, the absorption will be decreased for this patient. Next, isoniazid. Isoniazid will be the mycolic acid. This mycolic acid is present in this TB. Okay, the cellular the cell membrane which will be consisting of the mycolic acid, and if you damage that mycolic acid, the treatment will be effective, right? Isoniazid will be doing. And what are the side effects? Hepatotoxicity, peripheral neuropathy, and SLE due to the drugs. And this patient will be given for the B6 so that the neuropathy will be decreased. Pyrazinamide, very hepatotoxic, and this patient will be having the condition like hyperuricemia and hepatotoxicity will be seen. So that's why it is contraindicated in the patients of the pregnancy. Very highly hepatotoxic. Next, acidic environmental, these drugs are going to be activated. Next, coming to the last drug, guys, that is the ethambutol. Ethambutol, E for eye. Okay, it can cause the optic neuritis and the blindness. And same here also, cell wall synthesis will be decreased as a as a mechanism of action. It is contraindicated in the patients of the renal failure. Next, here you can see this is the app that is known as a NICSHI. Okay, and if you see the NICSHI, this is for the urine pregnancy kit, not for the TB. This is for the TB patient. And this is the dots we are going to give the patients with the TB treatment by the ASHA workers. Okay, this is the logo. National Tuberculosis Elimination Program, where you are going to see TB Mukt Bharat. Okay, next, coming to the resistance, guys. You have to understand the resistances. First, the first one is the mono resistance. The mono resistance is most commonly associated with the isoniazid. Second one, polydrug. Polydrug resistance will be seen with the multi-drugs. Okay, more than one drug will be involved. Okay, but this is not related to the rifampicin and not related with the isoniazid in the polydrug. Next, multi-drug resistance. Here, the both are resistant. Isoniazid and also rifampicin is involved. Next, fourth one, this is the pre-XDR TB resistance. That means multiple drug which will be resistance. Along with that, the fluoroquinolone is also resistant. Okay, either the patient will be resistant with the isoniazid, rifampicin, and plus fluoroquinolone also. Okay, next, extensive. This is known as a extensive resistance. This is going to be the patient will be isoniazid, rifampicin, and also one of the fluoroquinolone, and another drug bedaquiline, that is also resistant in this patient. Right? How can we know the resistance? The best test for this patient is the CBNAT. Okay, CBNAT should be ordered for the every sputum sample that you are going to order for this patient. Okay, the CBNAT is going to give. And next, interferon gamma. Interferon gamma is the going to decide the how the infection is present. Infection is present. Next, another test also we are going to do, right? Montauk's test. This is very rare nowadays we are going to do because positive in every patient also. And Montauk's test is a type 4 hypersensitivity reaction. Okay, this is the important points of the TB. Next, we are moving on to the discuss the leprosy topic, guys. Here you can see this is the classification. What is this classification known as, guys? Ridley-Joplin. Okay, this is known as a Ridley-Joplin classification. And further, if you see, this is how the lesions that we have to find. First, tuberculoid. Here you can see there are only few lesions you are going to see. 1, 2, 3. And all those are going to be hypopigmented. Here, like this, hypopigmented plaques will be seen and well demarcated. These plaques are well demarcated will be seen. Next, borderline tuberculoid. This is the most common in India. This is the most common form of the India. There will be 10 more than 10 lesions will be seen, guys. Okay, and satellite lesions also seen. Satellite lesions will be seen. Next, borderline type. The borderline type is going to be unstable type. So there will be more than 20 plus lesions. And all these lesions, which will be known as a geographic type lesions, right? Like map like lesions you are going to see. These lesions are known as a geographic asymmetric type of the lesions. Next, borderline lepromatous. These are going to be symmetric lesions. The lesions are symmetric and inverted saucer type. Inverted saucer appearances. Next, lepromatous completely. This you are going to see the leonine phases. Okay, abnormal phases due to nodules. Okay, multiple nodules, and also the patient will be having the severe neuropathy. Okay, And important points, what is the most common nerve that is involved here? Ulnar nerve. And the most common facial nerve in the CN nerves. Okay, in the cranial nerves it is facial, in the all nerves that is ulnar. Okay, that's the differences. Next, we also have to know about the what is paucibacillary, and other one is the multibacillary. So paucibacillary, that means the patient is having only less than 5 lesions. Multibacillary, more than 5 lesions. And no nerve involvement will be seen here. Here the nerves is already involved in this patient. Okay. And no contagious, yeah, less contagious comparing to the multi. This is highly contagious to the surrounding people. So treatment will be given for this patient 6 months. Here the treatment will be given for the 12 months. Okay. Next, coming to the treatment. What are the drugs that we are going to use? So the common drugs we are going to use is the rifampicin. Okay, rifampicin is given for this patient. How the rifampicin is given for this patient? 600 mg on day 1. Day 1, you are going to give the 600 mg. And next, dapsone. Dapsone is given like 30 days. Okay, it is given for the 30 days. And how much is the dosage? 100 mg per day. Okay. Next, clofazimine. Clofazimine is given only 300 mg on day 1. Okay. Then after that, you are going to continue 50 mg. Okay. After that, you are going to continue 50 mg for 30 days. Okay. Per day, 50 mg that you are going to cover. This is how the drugs are given for this patient. But they are associated with the reaction type 1 lepra reaction and type 2 lepra reaction. So this is associated with the type 4 sorry. This is associated with the type 4 hypersensitivity reaction, and here this is associated with the type 3 hypersensitivity reaction. So 1 plus 4, 5, 2 plus 3, 5. So the rule of 5 you have to understand for the this reactions of the condition. Next, type 1, this is due to neural. Okay, neural. So neuritis will be seen in this patient. Okay. Next, this here erythema nodosum. Okay, the erythema nodosum will be seen in this patient. So the difference is this one. Next, the multi-drug therapy, you have to continue or not. You have to continue. Along with that, you have to give the steroids. So both are given for this patient. Next, coming to the here, what are the drugs that you can give? Again, same, continue the MDT, and you have to start the patient on the thalidomide. Right, this is the two important things that you have to remember. And what is this logo, guys? NELP. Okay, this is the National Leprosy Eradication Program logo that we are going to see. Okay, next, moving on to the vaccines. So vaccines is a very vast topic. You have to understand only the important points. Okay, because very short time you have to understand importance only. Next, what are the types of vaccines? Let's see what are the live vaccines. BCG, okay, measles, mumps and rubella. So MMR vaccine is a live vaccine. Next, yellow fever rota vaccine is having the both. Okay, it can be killed is also present, the live is also present. Okay, next, chicken pox. Chicken pox is also present. Next, Sabin virus. Sorry, Sabin is going to be the polio live. Okay, Sabin polio is live OPV vaccine. Next, killed. So the killer types are hepatitis B, tetanus, okay, tetanus, and also pertussis, rabies, sorry guys, and IPV. IPV is nothing but Salk. Remember K for Salk, and this is the killed vaccine. Okay, that is the Salk vaccine. Okay, these are the killed vaccines, and some vaccines such as going to be both live and also killed. What are those vaccines? Polio, Japanese encephalitis, typhoid, flu vaccine, and also hepatitis A virus. Okay, next, polysaccharide viruses like PCV, pneumococcal virus, and meningococcal type is also going to be the polysaccharide. Next, recombinant type. This is the hepatitis B and also nowadays common one HPV vaccine. Okay, these are the types. Next, root. Via root, you have to understand nasal is only form that is present is the flu. Okay, oral, the name itself, most commonly rotavirus and OPV virus is given for this patient. Next, intradermal BCG is commonly given for the patient, and also rabies and IPV is given. Subcutaneous measles commonly given. Next, yellow fever and MMR type because it is a combination type. Next, intramuscular, all remaining. So whichever is I am not mentioned above, all remaining will be intramuscular. IV, nothing is given by a IV. Okay, that is the thing that you have to remember. Next, coming to the strains. Okay, what are the strains that is present in the vaccines? BCG. Okay, this is the very old PYQ, Danish 1331. Okay, next, measles, Edmonston. Okay, Edmonston, Jackberg. That is for the measles. Next, mumps for the Geraldine is for the mumps. Yellow fever, RA 27 by 3. Sorry, yellow fever is actually 17D. Okay, rubella, rubella, R for rubella and R for RA 27 by 3. Next, varicella is Oka virus. Okay, varicella is Oka virus, and Japanese encephalitis, if it is a live, it is SA 14 2. Okay, that is for the live. And if it is killed, Beijing type is for the killed. Okay, these are the some of the strains that you have to remember for the examination, guys. Okay. Next, coming to the protocol, how you are going to give how the vaccines are given. So at birth, you are going to give the BCG, OPV, zero dose, and hepatitis. At the 6 weeks, OPV 1, pentavalent 1, and rotavirus 1, and pneumococcal 1 will be given for this patient along with the IPV 1. At the 10 weeks, OPV 2, pentavalent 2, and rotavirus 2. 14 weeks, OPV 3, pentavalent 3, fractioned IPV 2, rotavirus 3, and PCV 2 is given. So at the 10 weeks, you are going to give only the 3 drugs, but in the 14 weeks, another 2 drugs that is coming here, IPV and the PCV2. At the 9 months, you are going to start the measles along with that vitamin A prophylaxis. And in the 9 months to 10 months, Japanese encephalitis is given, but only if there is a endemic areas. And PCV is only given 2 doses. After that, at 9 months, we are going to give the booster. 16 months, measles second dose, Japanese encephalitis 2 dose, and DPT booster, OPV booster is given. 5 to 6 years, DPT booster 2, 10 years tetanus toxoid, 16 years tetanus diphtheria, and pregnant woman TD1, TD2. For the pregnant woman, early first week of the pregnancy, you can give the first dose, and after 4 weeks, second dose is given. But if the mother is pregnancy is less than 3 years, then you can go for the booster. If it is more than 3 years, you have to repeat the another 2 doses again. Okay, this is how we are going to proceed for the patients, those who are taking for the pregnancy. Okay, this is the universal national program that we are going to follow. Okay, this is how we are going to follow. Then sometimes we are going to have the what is the gap. Okay, how much gap should be present for the live vaccines. So live vaccines, at least 2 to 4 weeks is enough. Okay, better choose the 4 weeks gap is important between these vaccines. Okay, that is the first thing that you have to remember. Next, coming to the dilutants. What are the dilutants we are going to use? And in the dilutants, most commonly used is the saline. Okay, normal saline we are going to use. And normal saline is mixed in the BCG vaccine, yellow fever, Japanese encephalitis, and influenza virus can be also used. For this patient also we can use. Next, distilled water. Okay, distilled H2O is commonly used for the MMR. Okay, next, these are the commonly used, guys. You have to understand. And additives commonly like a neomycin is additive for the measles vaccine, that is very rarely asked. Next, contraindications. Contraindications. All the live vaccines are contraindicated in the patients, those who are suffering from the pregnancy, and also those who are suffering from the decreased immunocompromised. We are not going to give any of these drugs. Then what is the drug that is given for the pregnancy people? Tetanus toxide is given for this patient. Okay, only tetanus toxide is given, remaining all are not given, but yellow fever also can be given for this patient. Okay, that is the another thing that you have to remember. And also those who have the anaphylaxis reaction, those who have the anaphylaxis reaction also, we are going to contraindicate all types of the drug. Okay, that is the first thing that you have to remember. Next, if the mother, if the sorry, if the baby is having the seizures with this drug, okay, especially DPT vaccine, then also it is contraindicated in the next dosage. Okay, next, associated patient with the side effects. The patients, those who are having the side effects. Usually, OPV vaccine, the patient will be having the paralysis. Okay, but this paralysis is associated with the P3. Okay, there will be three types: P1, P2, P3. But if it is from the vaccine, that is due to P3. Okay, next, BCG patient, that can cause the lymph adenopathy and also bone pain. Okay, bone pain is also seen in this patient. This is for the BCG. Next, measles, measles vaccine toxic shock syndrome will be seen. Flu, this patient will be having the Guillain-Barre syndrome will be seen. Rotavirus intussusception, right? Rotavirus patient also seen with the intussusception will be seen, right? This is the some of the important factors that you have to see. DPT, just now we discussed seizures. This seizures is also most commonly due to pertussis. Next, coming to the vaccine storage. So this is how the vaccine storage is seen, guys. Basically, we are going to store at the +2 to 8 degrees Celsius. This is the refrigerator we are going to use. And this is the one which will be carrying by the transport. Okay, this known as a vaccine carriers by the ASHA workers to the centers. Okay, this is the vaccine carriers. Okay, this thing is known as a cold chain. This is known as a cold chain process, and the temperature is +2 to 8 degrees that we are going to use. Okay, next, coming to the this feature, vaccine vial monitor. On the vaccine vial monitor, if it is seen the both are differentiating, we can use, and slightly differentiating we can use. But if it is not differentiating, we have to throw and discard this this we have to discard this two types of the vaccines that should be discarded immediately. Okay, that is the pattern that we are going to follow for the vaccine vial monitor. Okay, next, here this is completes the vaccine part, the dosages and important points. Next, moving on to the upper GI disorders. Okay, in the upper GI disorders, the conditions that you are seeing here: Jenkers, achalasia, Borhoff syndrome, and also those who are suffering from the GERD. Okay, let's see one by one, guys. First, here you can see this is the condition of the achalasia cardia. So in the patients, those who are suffering from the achalasia cardia, where is the most common cause? This is due to Killian dehiscence. Okay, the location is Killian dehiscence. So between the thyropharyngeus and the circopharyngeus muscles. So known as a false diverticulum. This is known as a false diverticulum. This condition is known as Jenker's diverticulum. Commonly seen with the patients, those who are males, old age people, we are going to see. So there will be feeling that the patient will be having the dysphagia, neck swelling, and aspiration can be seen for this patient. The best test to do is the barium swallow. Barium swallow should be done for this patient. And the classical treatment is diverticulectomy. It should be done. Next, this is the achalasia. So achalasia cardia is due to the failure to relaxation. Okay, this is the lower sphincter region, right? So failure to relaxation, which will be causing this condition. And if it is a failure to relaxation, the patient will be having early, there will be difficulty for the liquids. Okay, and after that, there will be difficulty with the solids also. But most commonly with the liquids, they are going to have the patients with this difficulty. And what is this appearance is known as bird beak appearances. Bird beak appearances. And if you see the rat tail, this is the esophageal carcinoma. esophageal carcinoma, you are going to see the rat tail. And what is the treatment of the choice for this patient? Usually, if we can go for the balloon dilatation, if it is not works, then we can go for the Heller's myotomy. Okay, Heller's myotomy, we can also proceed for this patient. Next, this is the condition of the GERD. Okay, regurgitation will be seen in this patient. So this patient is actually lack of the relaxation seen, and at the same time there will be reflex is also seen. Okay, reflex is also seen. And complication, what is the complications we can expect in this patient? Barrett's esophagus. Barrett's esophagus is actually metaplasia, but these columnar metaplasia can progress to carcinoma. Okay, what is that carcinoma, guys? Adenocarcinoma will be seen in this patient if it is progressed. Okay, and what is the surgery that we are going to do? Nissen fundoplication. Nissen fundoplication. We can proceed for this patient. What is the best test? The gold standard test for this patient is the 24 hours pH monitoring. And if you see there is a raise in the pH monitoring, then yes, likely to be the reflex regurgitation is present in this patient. Okay, next, this is known as a Boerhaave syndrome, and Boerhaave syndrome is associated with the rupture of the lower esophageal sphincter. Okay, where it is going to be due to binge eating. Okay, and if it is progressed, this is can cause the pneumomediastinum. It can cause the pneumomediastinum. So here you can see the rupture which will be leaked into the mediastinal structure, and pneumomediastinum will be caused in this patient. Okay, next, viral inclusion bodies. So in the viral inclusion bodies, intracytoplasmic or intranuclear. Intracytoplasmic or some of the example molluscum contagiosum, rabies, smallpox, fowlpox. Okay, Henderson Anderson. Okay, here you can see this is the picture of the molluscum. Okay, Anderson bodies, and Guarneri bodies, smallpox patient, and sometimes Pashnian bodies also seen in the smallpox. These are the Negri bodies seen in the rabies patient. And coming to the intranuclear, it can be acidophilic and the basophilic. Acidophilic, again two types, quadri A for the herpes simplex, varicella, and yellow fever. Here, basophilic, only B for basophilic, B for the quadri B, seen in the adenovirus and the cytomegalovirus. Cytomegalovirus, you are going to see the classical condition owl's eye appearances. This is the CMV. This is also owl's eye appearance, but these are the Restenberg cells. These are the Restenberg cells seen in the lymphoma. Right? Next, this is the giant cell appearances. This is known as a giant cell appearances seen in the patients of the measles. Okay, at least remember these important types of the viral inclusion bodies, and HSV1 and HSV2. So what is the difference between the HSV1 and the HSV2? HSV1 is associated with the cold sore, and HSV2 is associated with the genital ulcers. Okay, and this is commonly seen with the droplets also, and this can be associated with the STD. So this is the difference between the HSV1 and the HSV2. Next, rickettsial diseases. In the rickettsial diseases, what is the vector, disease, and the species that you have to remember? So the Rickettsia prowazaki, which will be causing the epidemic typhus due to lice. Next, Rickettsia going to cause the Rocky Mountain spotted fever due to the ticks. Next, Orientia susugamusi is going to be the scrub typhus due to mites. Next, another one you have to remember, Q fever. The Rickettsia australis due to again ticks. Okay, Rickettsia typhi, Morin typhus due to fleas. Okay, at least remember these four. So sometimes here you can see the picture can be also Rickettsia parkeri, Rickettsia aulicis, these kind of the rash, papulo-pustular will be seen. And Rocky Mountain fever, the papules will be seen in this patient. These issues are seen in the patients of the scrub typhus, patients will be seen. Okay, next, moving on to the contraception. So what are these contraceptive agents, guys? So here you can see what are these structures. This one is the Lippis. This is known as a Lippis loop, right? These two are the third generation copper T. Okay, these two are the copper T type. Next, this is the Mirena. Again, these both are going to be Graffinton rings. Okay, Graffinton rings. So important points that you have to take note of these structures. of this important contraceptive identification, guys. And at the same time, you also have to know about the what are the important points that you have to take note. First, half-life. When I talk about the half-life, copper T half-life is important. Okay, this is copper T 380. Okay, so the half-life will be 10 years for this. This is copper T 375 ends with 5. This is going to be half-life 5 years. Next, Mirena is also hormonal type. This is also 5 years. Okay. Next, this is the Anthara. And what is the dosage of the Anthara, guys? So, the Anthara dosage will be DMPA. This is a portal type. Total consists of the 150 mg given IM for every 3 months. And here, this is the Mala OCP. And OCP, what is the Mala contents that is present, guys? Ethyl estradiol. It is going to contain the ethynyl estradiol of 0.03 mg, and along with that OCP oral contraceptive pills 11 orgosterol 0.15 mg. Okay, next coming to this one, this is the non-hormonal, okay, and known as a chaya. Here you can see this is the chaya, and it consisting of the ormilexifone, okay, ormilexiflin, which is SERM agent, okay, selective estrogen receptor modulator, non-hormonal and non-steroidal type of the patients. Okay, next here, this is the barrier. This is for the female condom. This is for the male, and here this is known as a patches. Okay, estradiol patches that we are going to see. Next, coming to the contraindication, the question that is asked in the examination last year also. So for the copper, let's see, this is the IUCD, guys. IUCD. For the intrauterine devices, the complete contraindication, that means absolute contraindication, PID or patient those who are suffering from the active infections. Okay, next, unknown bleeding, okay, or we can say AUB, or we can say this is the abnormal uterine bleeding. Okay, and patient is pregnant, and also those who are having the anomaly, uterine anomaly, or patient is having the large fibroid, okay, and those who are suffering from the Wilson's disease, and history of breast cancer. Hormonal is not given, right? Next, relative contraindications. Relative contraindication, history of PID less than 3 months, okay, and suffering from the severe anemia because bleeding is expected, and history of partners, multiple partners, okay, and patient is suffering from the nulli gravidity. Okay, this is also, and ectopic pregnancy is also relative contraindication. Next, OCP contraindications. Absolute OCP contraindications will be thrombosis, contraindicated like thrombosis, and patients those who are suffering from the severe liver disease, and breast cancer. Patient is suffering from the breast cancer, lipid disorder, and severe cardiovascular disease. Okay, next, coming to the relative, migraine, migraine condition, or female, the age is more than 40 years, or female age is less than 35 years, but history of the smoking is seen. And those who are suffering from the diabetes mellitus, hypertension, and liver dysfunction. Okay, these are the contraindications for the OCPs. Next, moving on to the Duke criteria. So for the coming to the Duke criteria, where you are going to follow this Duke criteria, guys, infective endocarditis. This is seen in the patients of the infective endocarditis. Okay, first, infective endocarditis, we are going to use this Duke criteria to diagnosis. But what is the common cause for the infective endocarditis? The most common cause, for this patient is Staph aureus. Okay, this is going to be Staph aureus. Okay, then subacute type, we also have the subacute type. This is due to strep viridans. Strep viridans is going to be subacute type. Okay, next, if the patient, those who are transmitted by the valves, this is due to valves like prosthetic valves. Prosthetic valves also, it is going to be Staph aureus. It can be again due to Staph aureus. Okay, but if it is less than 3 months, less than 12 months, less than 12 months, then it is epidermititis, streptococcus epidermidis. And if it is more than 12 months, this is due to viridans. Okay, it will be changing different types of the organisms. Okay, another important point that you have to take note. So this patient can be associated with the IV drug abuse. Okay, IV drug abuse. For this patient also, staph aureus is most common, but right type of the heart failure which will be seen in this patient. Okay, because the right side of the patient most commonly vein will be abused. Next, there are the two different criteria. One is the major, other one is the minor. So what you have to see in the major criteria, there should be positive blood pressure, two or more blood pressure 12 hours apart, or three or four major blood culture should be positive, that at least each one will be one from the last sample that you have taken. And along with that, either you are going to show the positive culture or else you can show the echocardiography positivity for the patient, where you are going to see the vegetations in the endocardium. Next, minor criteria, predisposing factors like heart conditions, IV drug abuse, fever, vascular phenomena, immunological phenomena, microbiological findings. Not from here. The microbiological findings will be separate. That will be seen. Okay, vascular phenomena or the immunological phenomena means the patient will be suffering from the glomerulonephritis, or the patient is suffering from the ossular nodes and Janeway lesions. Okay, Janeway lesions. And on the eye retina, you are going to see the Roth spots. If these any of the following present also, we can consider as a minor. When you are going to diagnose the confirmed diagnosis, if you see positive echocardiography, positive culture, then it is diagnosed. Or one major, three minor, or at least five minor should be positive. And false cardiography, sorry, possible infective carditis, one major, one minor, or the three minor criteria. But this is the best that you are going to find. And each one will be given the one point. Okay, that is how you are going to proceed. Next, moving on to the Jones criteria. So Jones criteria is used for the patients who are suffering from the rheumatic fever. Okay, in the patients of the rheumatic fever. And important points that you have to take note, it is subdivided into the low risk and high risk. Okay, what about the India? India is most commonly comes under the high risk. So better you know about the India criteria, that is the high risk, guys. So what are the symptoms for the Jones criteria? Major carditis, arthritis, chorea, erythema marginata, subcutaneous nodule. Minor criteria, fever, monoarthralgia, ESR more than 30, and prolonged PR interval on the ECG. Okay, first overview of the rheumatic fever. Why the rheumatic fever is seen? Most commonly post strep infection. This is going to have this condition which will cause the cross reactivity. Okay, this will cause the cross reactivity in our body, which will be seen as this condition. Okay, next, rheumatic fever is going to use the M proteins. These M protein which will be affecting the heart, carditis, joints, and also neurons. Okay, multiple factors will be involved due to the M protein and this condition. And if you progress this, heart will be including the rheumatic heart disease. Okay, in the rheumatic heart disease, the most common valve that is involved is going to be mitral. Okay, first the patient will be having the mitral stenosis. If it is progressed, mitral regurgitation is also seen. Okay, what is the deformity that you are going to see here? Fish mouth deformity you are going to see. Fish, fish mouth deformity will be seen in this patient. On the biopsy, you are going to see the Ascough bodies. In the biopsy, you are going to see the Ascough bodies that is seen in this patient. Okay, next, another important thing, if there is a subcutaneous nodules, it is directly proportional to the carditis. That means if it is a nodule, if you see, yes, the carditis is also included in this patient. Then how can we are going to diagnose? So at least two major or one minor, sorry, one major plus two minor. Then we are going to characterize this as a rheumatic fever. Along with that, there will be also titers that is also positive. Okay, ASO titers is also going to be positive in this patient. Okay, this is the how we are going to use. Next, what is the drug of the choice for this patient? For the drug of the choice, we are going to start this patient on the penicillin. Okay, penicillin is given for this patient, and also aspirin for the anti-inflammation, anticoagulation. Okay, that is also given for this patient. Next is steroids. Steroids is given to decrease the other nodules and everything, and other drugs like phenobarbital. Phenobarbital is given to decrease the chorea symptoms. Next, coming to the prophylaxis. Okay, how the prophylaxis is given? That means the patient is does not have no carditis. Then you are going to give the benzathine penicillin for 5 years up to 21 years. Okay, next, but the patient is had the carditis. If the carditis, benzathine penicillin for 10 years to 21 years. Next, RHT is also seen. Then more than 40 years, you are going to give this benzathine penicillin. Okay, this is how we are going to give these drugs for the patients, those who are suffering from the rheumatic heart fever. Okay, this is the overview and important points that you have to take note. Next topic we are going to discuss is the lung diseases. In the lung diseases, important scoring and the criteria. First one is the curve 65 score case. What is meant by the curve 65? C for confusion, U for urea more than 7 ml, 7 millimoles, and R for respiratory rate, and tachypnea, and S for systolic BP, hypotension. Okay, and 65 is for the age, and each one is given for the 1 point. And if you see 0 to 1, then that you have to give for the outpatient, and if it is 2, general ward admission. If it is more than 3, ICU and ventilation is needed for this patient. Okay, next, coming to the gold criteria. Gold criteria is for the patients of the COPD. If it is less than 0.7, more than 80% of the fraction, then you have to consider this as a mild. And gold 2 for the 50 to 80% of the FEV1, and for the moderate. Coming to the severe, it is 30 to 50% of the FEV1 fraction. Okay, next, gold 4, very severe, less than 30. Okay, and what is the best treatment for the patients, those who are suffering from the COPD, guys? Oxygen for 15 to 16 hours that you have to give. This is the best treatment that we can give for this patient. Next, coming to the Berlin's criteria. This is known as a Berlin's criteria, used for the ARDS, okay, acute respiratory distress syndrome. What are the important components? Time, okay, at least less than 7 days from the presentation. Next, pulmonary edema, that not be from the cardiac cause, it should be only from the lung cause. Radiological features, infiltrate should be seen on the chest X-ray or the CT, and the percentage of the hypoxemia, it is given as a mild, moderate, severe. So if it is from the 200 to 300, mild, moderate is the 100 to 200, severe is less than 100. Okay, this is how we are going to see. And what is the treatment? That is mechanical ventilation should be attached. What is the mechanical ventilation attachment, guys? You have to decrease the tidal volume. Okay, that means 6 ml per kg you are going to give, and PEEP is increased. Okay, PEEP is increased for this patient. So this is the settings that we are going to do for the mechanical ventilation. Next, lights criteria for the pleural effusion. Okay, and three different, we are going to differentiate, either it is exudative or the transudative. If lights criteria is positive, then that is likely to be the exudative cause. Compulsory, most commonly, that is from the pneumonia. And pleural fluid and the serum protein more than 0.5, pleural fluid and the serum LDH more than 6, or only the pleural fluid LDH which will be more than 2/3 of the serum limits. So if any of this one is positive, then it is the exudative. If none of this positive, then it is transudative cause. These are the lung scores. Next, coming to the liver diseases. Liver diseases and the scores. First, here you can see this is the MELD score. So MELD score is important for the transplantation. Okay, what are the components? You don't have to remember the formula, you don't have to remember the what are the points, but what are the components is important. In the MELD scoring, bilirubin, INR, creatinine, sodium, these four are important, and criteria is for the transplantation. Next, this is known as a King's criteria. Okay, King's College criteria. Either the patient is having the paracetamol toxicity or non-paracetamol induced, or the patient is having the acute liver injury. Okay, If the pH is less than 7.3 or any of this INR, serum creatinine or the grade 3 encephalopathy, this is known for the paracetamol toxicity. Non-paracetamol, again INR is more than 6.5 or the patient age is less than 11. Etiology is other than the causes like hepatitis, time of the onset and INR more than 3.5, serum bilirubin. These are the criteria for the paracetamol poisoning. Next, another one here you are going to see the child bug score. Okay, this is the child bug score. So in the child bug score, again the scoring components is not important, but what are the important criteria? Encephalopathy, ascites, bilirubin, albumin and the prothrombin type. This is we are going to use. Okay, next coming to the liver function test. Liver function test we are going to see. First, ALT, which is also known as your SGPT. This is more specific for the liver. This is more specific for the liver. Next, AST, this is the SGOT. Okay, this is for the liver. At the same time, it is also seen in the muscles. Okay. Next, for the viral causes, ALT, viral causes, you are going to see ALT is more positive than the AST. Okay, because it is a liver specific, guys. Okay, next AST ratio, AST and the ALT ratio is more than 2.1, then this is likely to be from the alcohol. Okay, this is from the alcohol. Next, GGT is more specific for the alcohol, especially for the chronic patients. You are going to see the alcohol. Next, you also have the 5-nucleotidase. 5-nucleotidase is also positive. This is from the cholestasis. Okay, cholestasis. This is going to be positive, right? Next, ALP. ALP. This is also for the cholestatic markers. Cholestatic markers. Okay, serum bilirubin, you also know conjugated, unconjugated, for the especially which are the conditions like, so who is supposed to be the jaundice. Okay, this is how we are going to see the LFT patients. Next, moving on to the hernia. In the hernia, the major differences which will be seen between the direct and indirect hernias. Okay, first thing, what is the location of the direct hernia or the indirect hernia? Let's see here. So we are going to differentiate indirect hernia. Here you can see indirect hernia here. So most commonly the indirect hernia which will be seen in the lateral to, this is lateral to inferior epigastric vessels. Lateral to inferior epigastric vessels. Okay, next direct hernia. This is going to be medial to the epigastric, inferior epigastric vessels. Okay, first difference between the direct and indirect. Most common overall, this is going to be the indirect hernia. So indirect hernia is directly coming into the tube. It can even go to the scrotum also. But direct hernia, it is from the other side, like muscle fascia, it is going to be seen. Okay, first thing. Next, the indirect hernia, as we said, this is coming indirectly into the inguinal canal, and a direct canal is from the posterior wall. Okay, that is the two differences that you have to see between the direct hernia and the indirect hernia. Next, you also have the classification here. This is New York classification for the inguinal hernia. How you are going to see? Type 1 is going to be indirect hernia with inguinal ring on the normal size. Next, type 2 indirect hernia that going to show the dilated internal inguinal ring. This is the presentation. Type 3 posterior inguinal wall. Okay, that is coming from the direct hernia. This is going to be direct hernia. 3A direct inguinal hernia. 3B indirect hernia with posterior floor also defect. Okay, 3B indirect hernia and at the same time posterior floor defect. 3C femoral hernia. Okay, there will be 4 also. So the 4 hernia is the recurrent hernia. 4A for the direct recurrent, 4B for the indirect recurrent, 4C is for the femoral recurrent. 4D is like a combination either AB or BC or CB. Like that it is going to be seen. Okay, next there are many types of the hernias is also presented. Okay, epigastric hernia where it is going to coming from the xiphisternum region. Okay, xiphisternum to umbilicus. Okay, next umbilical hernia. that is seen in the patients of the newborns, right? Newborn patient you are going to see, and those who are suffering from the hypothyroidism, congenital hypothyroidism patient, and also this syndrome. Yesterday we discussed this syndrome, guys. Prader-Willi, sorry, not Prader-Willi, Patau syndrome. Okay, Patau syndrome patients also having this umbilical hernia. Okay, and 2 years wait and watch only. You are not going to treat this patient, and 2 years wait and watch only for the umbilical hernia. Next, para umbilical, that is adjacent to umbilicus. Okay, adjacent to umbilicus, and you also understand this has to be treated promptly. Why? Because high risk for the strangulation. Very space is very narrow, and this can cause the strangulation. Next, Litre hernia is associated with the Meckel's. If it is a Meckel's, that is associated with the Litre. Okay. Next, middle type of the hernia, more than one bowel plus wide defect, that is known as a Middle's hernia. Okay. Next, another one is the Richards hernia. Richards hernia. This is seen with the femoral plus paraumbilical. This is seen as a Richards hernia, and very the big defect that is known as a major one, that is a Spigelian hernia. Okay, this is occurs at the rectus muscle. This is present at the rectus muscle of the hernia. Okay, this is the features of the different types of the hernias, direct and the indirect differences. And next we are going to discuss about the ECG. In the ECG, you are going here, you can see, guys, these are the bradyarrhythmias. Okay, these are the bradyarrhythmias. So first here you can see this is the first degree heart block. So there is a PR prolongation. So you only see PR prolongation. Okay, more than 200 milliseconds. No treatment is needed for this patient. Next, second degree heart block, which is known as a Mobitz type 1 or the Venke back. So what happens here? The PR prolongation is seen. PR prolongation is seen, and then sudden drop of the QRS. QRS drop is also seen. Right? This is the second degree. Next, second degree, another type, that is the Mobitz type. So there will be PR interval which is normal, but there will be QRS complex drop. This is how. Okay, this is the defect. Second degree Mobitz type 2, PR interval is normal, but QRS is drop. Next, it can be 2:1 block also. Okay, like normal, two types of the normal, then block, then two normal, then block. That is the 2.1. Next, third degree heart block, complete collapse, no relation. Okay, there is no relation between the QRS complex and also P wave. That is for the complete heart block. So second degree and the third, for this patient, the treatment will be pacemaker. For this both patient, we are going to give the pacemaker. Next, moving on to the tachyarrhythmias. Okay, moving on to the tachyarrhythmias. In the tachyarrhythmias, you have to understand what is the treatment and how to identify these structures. Okay, first thing, here you can see what is this? This is the irregular period. Okay, the period from the RR intervals is irregular, and at the same time P waves are absent. So this is the classic condition, atrial fibrillation. For this patient, if the patient is stable, go for the echocardiography and start the patient on the platelets therapy and also amiodarone. If the patient is unstable, then go for the cardioversion. Okay, go for the cardioversion for this patient. Okay, next, moving on to the three different types of the P. Okay, here you can see the P interval is three difference. So this is known as a multifocal atrial tachycardia. For this patient, the treatment of the choice is the beta blockers, and most commonly this is associated with the COPD patient. Okay, pneumonia, COPD, heart failure patient. Next, this is the sawtooth appearances. Sawtooth appearances is seen in the atrial flutter. This is seen in the atrial flutter. Here also beta blockers is the treatment of the choice. Okay. Next, this is PSVT, and here PSVT is regular, but P wave is absent. P wave is absent in this patient. What is the drug of the choice for this patient? Adenosine is should be given for this patient immediately if the vitals are stable. Again, if the vitals are unstable, then you have to go for the cardioversion. Next, most common type of the children. If in the children, the most common type is the PSVT. If it is adults, that is atrial fibrillation. Okay, another important point that you have to take note. Next, here you can see PER interval is short and there is a delta wave. What is this condition, guy? Wolf Parkinson White syndrome. Wolf Parkinson White syndrome. That is the patient those who are suffering from this one. Next, treatment of the choice for this patient is the prokinamide. Prokinamide is given for this patient treatment. Next, here you can see another conditions. What is this condition? First one, this is the ventricular tachycardia. For the patients of the ventricular tachycardia, this is divided into the two types. Ventricular tachycardia without pulse, ventricular tachycardia with pulse. Okay, if the with pulse stable, then you are going to give the amiodarone for this patient. Okay, without pulse, then defibrillation should be attached. Defibrillator should be attached. Next, this is the increased QT prolongation, also known as a torsades de pointes. Drug of the choice for this patient is the MgSO4. Okay, next, this is the VFib. VFib patients and VTAC without pulse, right? Just now discussed. So for this patient also, we are going to go for the defibrillation. Defibrillation is attached. So this is the ECG overview. Next, moving on to the valvular heart diseases. In the valvular heart diseases, I want you guys to know about the important points only. First, what is meant by the stenosis? That means here you can see the valve is already closed and stenotized, right? That is for the patients of the stenosis. That means the patient will be already closed valve is opening, which is causing the regurgitation. Next, coming to the regurgitation, already, sorry, come back to the valvular heart diseases. What I was telling is the valve is closed, but it is coming again. That is known as a regurgitation. The valve is open, but narrowly open. That is known as a stenosis. Okay. And how to differentiate between the, is it the systolic murmur or the diastolic murmur? For that, remember this cardiac cycle. First, you are going to have the isovolumetric contraction. So once the isovolumetric contraction is done, it is going to cause the rapid rapid ejection, and rapid ejection, then slow ejection. Okay, slow ejection. Here S1 sound is caused. Next, isovolumetric relaxation, rapid filling and slow filling. Right, this is how we are going to see. And in this one, there is a systolic phase and the diastolic. So this is known as a systolic, and this whole phase is known as a diastolic. So you have to understand where S1 and S2 is seen. Okay, here the S1 and here the S2 is seen. So what is the cause of the S1, guys? First, S1 is due to aortic and pulmonic is open. Okay, in the systolic, right? S2 is due to, again, what is the S2 sound which is caused when the aortic and pulmonic is closed, right? This is happened in the diastolic. Opposite to that, you can write this well also, mitral and tricuspid open, here mitral and tricuspid close, right? So intravascular, isovolumetric contraction, then isovolumetric relaxation, then again isovolumetric contraction. So this is the phase of the systolic, right? This is the phase of the diastolic. So the murmurs whichever is opening in the systolic is most commonly caused by the, which are opening in the systolic phase, the mitral and the tricuspid is closed, aortic and the pulmonic is open. So aortic stenosis, pulmonary stenosis going to cause in the systolic murmurs, and mitral regurgitation, tricuspid regurgitation because they are closed. Next, here mitral stenosis, tricuspid stenosis and aortic regurgitation, pulmonary regurgitation. In the diastolic phase, they are causing this murmurs. That's how you can easily remember. See, this all are going to see here. For example, so aortic stenosis, guys, where it is happening between the S1 to S2, right? This is how the systolic murmur will be seen. Crescendo and decrescendo pattern that is seen in the aortic stenosis patient, right? First thing. Next, here you can see pulmonary stenosis. Again, this is the systolic murmur that is caused. Okay, opposite to that, if there is a murmur that is coming here, then that is a pulmonary regurgitation. Okay, next PDA, you are going to see the continuous murmur. VST, this is how the systolic murmur will be seen, and early systolic murmur that is seen in the patients with the atrial septum defect. Okay, and slow murmur, okay, and mid systolic murmur seen in the hypertrophic obstructive cardiomyopathy. Okay, this is how the murmurs that will be presented. Okay, and some of the important murmurs, if you have to remember, AS, this is going to have the early systolic murmur, which is known as a crescendo decrescendo murmur. Okay, next aortic regurgitation, the name that is known as a Austin Flint murmur. Austin Flint murmur, and water hammer sign is positive. Water hammer sign is positive. Collapsing pulse that is seen in this patient. Pulmonary stenosis, the patient will be having the systolic murmur, but this is associated with the Noonan syndrome. Okay, Noonan syndrome, and also VS and also TOF patient, tetralogy of palate patient. PR is going to be Graham still murmur. Okay. Next, patients those who are suffering from the MS, pansystolic, murmur, and next MR patients, mid diastolic. Okay, mid diastolic murmurs. These are the some of the murmurs that you have to remember for the valvular heart diseases. Next, coming to the ABG. So in the ABG, here you can see this is the most important topic, guys. ABG. Commonly, at least one question is asked. So this is test is known as a Allen test. This test is known as a Allen test. So in the Allen test, you are going to check the ulnar and radial arteries whether they are present the intact circulation or not. Okay, this is the Allen test. So next, we are going to check the pH value. pH normal is 7.4. PCO2 normal is 40, and HCO3 normal is the 24. Remember this way, 444. Okay. Next, if the here you can see the respiratory acidosis. Acidosis, the pH is the primary defect. Okay, primary defect, and remaining values going to decide is it the respiratory or the metabolic. So always remember the respiratory is opposite to the pH. If the pH is low, respiratory will be high. Okay, but metabolic will be same way. Okay, this is the difference that you have to observe. If you see respiratory pH is low but the PCO2 is high, then this is the respiratory condition, and metabolic will be same. So here the differences that you can observe. Okay, next, coming to the compensation. So how the compensation will be seen, guys? If you use the compensation with the Winter's formula, with the help of the Winter's formula, so Winter's formula tells us, for example, if it is a respiratory condition, it can be acute or it can be chronic. Okay, so respiratory acidosis, and also you have the respiratory alkalosis. Here also acute and chronic. Okay, so how they both are presented, guys? For example, every PCO2, and here also every PCO2, there should be compensation by what? HCO3. Okay, HCO3, there should be a compensation that should be presented. So Winter's formula Winter's formula is going to tell us how this compensation has to be maintained. But if you sometimes the Winter's formula which will be confusing in the examination, so to avoid that, just remember this mnemonic, guys, so that you won't be confusing in the examination. Okay, first thing, so I will tell this very simple formula that you have to be mug up. For example, if there is a acute respiratory acidosis, for the every PCO2 increase, for the every one PCO2 increase, how much HCO3 has to be increased? 0.3. 0.3 EQ also has to be increased. If it is a chronic 1 PCOT, there will be 4 times of the HCO3 has to be increased. Again 1 PCO2, then it is 0. How many has to be decreased for the alkalosis? 0.2. Okay, then 1 PCO2 decrease 4. So just simply you have to see this. The differences is here 0.3, 0.2. So 4 is same for the chronic. 4 is same for the chronic. Next, coming to the metabolic types. Okay, for the metabolic acidosis, for the patient of the metabolic acidosis, if there is a one, if there is a 1 HCO3 decrease, there will be decreasing of 1.3 PCO2. Okay, if it is a metabolic alkalosis, if it is a metabolic alkalosis, for every 1 HCO3 increase, there will be 1 PCO2 increase. Okay, 1 PCO2 will be increased. Sorry, there will be, sorry, 0.7 guys. 0.7 PCO2 will be increased. Okay, this is the Winter's formula. If you don't have to be confused with the Winter formula, divide this as a partial, full compensation and no compensation. So just by the formula, just not by the formula. For example, partial patients, usually what happens in the partial patients, the commonly the compensation is either the different ways. Okay, the partial compensation is already started. pH is decreased, PCO2 is decreased, and HCO3 is decreased. So partially, so this is the metabolic acidosis. Already PCO2 is started its compensation. Next, fully compensated, pH is going to be normal. Okay, pH is going to be normal. That is known as a fully compensated. And no compensation is started, it means, okay, here this is how it is going to be presented. And again, it is a metabolic acidosis, but pH is down, HCO3 is down, but PCO2 is normal. That means compensation is not yet started. This is how you are going to differentiate it. Next, you also have the Hagma here, sorry, anion gap. So anion gap can be associated with the metabolic acidosis. Either it can be high, so which is known as a Hagma, and or it can be Nagma, normal anion gap. So what, sorry guys, what are the conditions? First, DKA, lactic acidosis, glycol poisonings, okay, glycol poisonings, or patient with the methanol poisoning and salicylate poisoning, okay, like aspirin poisoning. Next, Nagma, this normal condition that will be seen in the patients of the saline and patients with the saline infusion or TA condition or vipoma like diarrhea condition, or those who are taking the spironolactone. So next we will be discussing about the glute transporters. Okay, remember that the mnemonic of the Lakshmi Rani Lakshmi Bai, made India proud. Okay, made India proud. So they are five, right? Glute 1 and glute 2, glute 3, glute 4 and glute 5. So R for RBC, L for liver, B for brain, M for muscle, and I for intestine. Okay, I for intestine. So the proud is nothing but just for the mnemonic. So what other present here guys? RBC, so blood brain barrier will be also present. Next, liver, in this place only you are going to have the pancreas. Pancreas is also going to have the glute 2. Next, here brain and sperm, which will be consisting of the glute 3. Next, muscle, what we discussed, and fat also consist of the glute 4, and also heart. Glute 5, wholesome, it is only for the glue intestine purposes. Next, SGLT also present here. SGLT1 and SGLT2. SGLT1, which will be presenting in the liver, and SGLT2 is present in the kidney. Okay, 2. This is for the SGLT. Next, we also have the LDH. Okay, LDH. LDH1 is for the heart. You only have the one heart. 2 is for the RBC. 3 is for the lungs and also platelets, pancreas, and lymph nodes. Okay. Next, 4 is for the liver and muscle. And same as 5 also, liver and muscle. Liver and muscle, which will be consisting of the 5. Next, we also have the GAGs, glycosaminoglycans. Okay, heparan sulfate present in the kidney basement membrane. Okay, next, chondroitin sulfate. This is present C for chondroitin, C for cartilage. Next, keratin sulfate seen in the cornea transparency. Dermatan Dermatan is present in the skin and vessels. Okay. Next, hyaluronic acid. This is present in the synovial fluid. These are some of the important GLUTs and say SGLT, LDH, and the GAGs. So liver, that means in the sense this is in the intestines case. Okay, small intestine, not wholesome in the liver. It is present in the GI system like small intestine. Next, epidemiological studies. So in the epidemiological studies, you have to understand what are the important types that is present here. So basically the studies, whichever we see, epidemiological studies is divided into the observational, and some of them are present as a experimental. Okay, experimental, we all know that those are evidence-based medicine and randomized control trials, randomized control trials or the non-randomized control trials. These are going to be into the experimental. And in the observational, you have the descriptive, like case series, case reports. Okay, this case presentation is the descriptive. Next, another type is the analytical. So analytical exams are we are going to see. So the first analytical type is the cohort study, which is also known as a prospective study. So this prospective study is going to be looking for the future. Okay. For example, you took the population and you are going to see for the disease progression. First, how you are going to see is the patient is exposed or is the patient is non-exposed. Okay, so seeing into the future, that is known as a cohorts study. Okay, you are going to look for the cohort study. So the cohort study calculated for the patients like relative risk, how much is the relative risk, and also how much is the attributable risk, how much is the population attributable risk, we are going to see. And this is going to give the temporality, how much is the related to the temporality you are going to see. Next, case control study. So you took the cases and controls. You are going to look back whether they exposed or the non-exposed. So you are going into the past of the patient. So this is known as a retrospective. This is known as a retrospective, calculated by the odds ratio, and it is best to check for the rare diseases of the patient. Okay, this is the case control study. Next, cross-sectional on the longitudinal. So cross-sectional at a point present day you are going to see, but the study for this one is going to be individual. Okay, individual you are going to see and calculates the prevalence. But longitudinal are also known as a ecological. So here you are going to see the population at a time. So the study unit of the study is population. Okay, this is the some of the important types and their epidemiological studies and their ratios that you are going to see. So for the calculation part, guys, please revise the video present in our YouTube channel, PSM formulas, first part and the second part. Next, moving on to the pemphigus disorders. So here the important pemphigus disorders you can see. What are those important pemphigus disorders, guys? The pemphigus vulgaris and the pemphigus foliaceus. So the pemphigus vulgaris is the most common. Okay, pemphigus vulgaris is the most common. Overall, this is the most common. Next, what are the antibodies present? Desmoglein 3 and the desmoglein 1. Next, in the foliaceous, it is just desmoglein 1. So the main differences is, so there will be oral lesions present in the vulgaris and no oral lesions present in the foliaceous. Coming to the histopathology, so the tombstone appearances at the suprabasal layer, this is pemphigus vulgaris, and subcorneal layer acantholysis, this is the pemphigus foliaceus. This is the difference pattern that you are going to notice. and direct immunofluorescence IgG net-like that is present in the pemphigus vulgaris, and same pattern is seen but most superficial seen in the pemphigus foliaceus. The treatment for this patient is the rituximab is given for the patients of the pemphigus vulgaris and steroids is given for the patients of the pemphigus foliaceus. Next, another condition that you can see here, this is known as a pemphigus bullous pemphigoid. Sorry, this is known as a bullous pemphigoid. And this bullous pemphigoid is seen in the elderly. This is seen in the elderly. And this bullae, if you observe, this is a tense bullae. Okay, this is a tense bullae, but still it does look tense, but it doesn't rupture. So it takes very time to rupture. And what are the antibodies that is associated? That is 180 and 1 to 30. This is the antibodies that is present in the desmosomes. And the treatment of the choice for this patient is the steroids. But what is the differentiating factor here? The Nichols sign. Okay, the Nichols sign is negative. The Nichols sign is negative in this patient. When it is comes to the pemphigus vulgaris and the foliaceus, the Nichols sign is positive. Okay, next, this is condition. So this is seen in the child known as a dermatitis herpetiformis. Okay, this is known as a dermatitis herpetiformis seen in the patients of the celiac disease. Okay, celiac disease. Next, moving on to the hair disorders. So in the hair disorders, at least remember these few things, guys. Like commonly asked questions only. Male pattern baldness. First, male pattern baldness. So what is the most common cause for the male pattern baldness? This is due to DHT. Okay, dihydrotestosterone, which will be causing this patient with a male pattern baldness, which is the most common worldwide. Right. Next, there is a alopecia areata. Alopecia areata. So alopecia areata patient, this is an autoimmune condition, and on the histopathology, you are going to see under the microscope exclamation mark. Okay, you are going to see the exclamation mark that is classical in the alopecia areata. Next, telogen effluvium. So this is most commonly associated with the post-infection, like patients those who are suffer from the COVID-19 and also from the stress, the hair fall is seen. Next, anagen effluvium. So anagen effluvium, this is seen with the chemotherapy or radiation. This is known as for the anagen effluvium. Next, trichotillomania. Trichotillomania. So this trichotillomania we discussed in the psychiatry hair picking OCD. This is kind of hair picking OCD. If they eat, it can form the trichobizar seen in the surgical case. Okay, this is the different types of the hair disorders. Next, drug of the choice for the male pattern baldness. Most commonly, we use the minoxidil, and also finasteride. Right. Next, for the patient here, the drug of the choice is the steroids. This is how we are going to see the hair disorders. Next, moving on to the acne. The acne is most commonly caused for the bacterial propionio or also known as a Cutibacterium. Okay, next, there are the four different grades that is present. Grade 1 is a mild, only the comedones will be seen, and this patient is given the topical retinoids. Okay, next, grade 2, there will be comedones, also papules, pustules will be seen. Topical retinoids, at the same time, topical antibiotics is given for this patient. Next, grade 3 is pustules and inflammation is also seen. So that's why oral antibiotics plus the topical retinoids is given. Grade 4, it is a very severe nodulocystic, extensive nodules and scarring is seen. For this patient, we are going to start on the oral isotretinoin for this patient. But oral isotretinoin is pregnancy contraindicated. Due to this, the patient is going to have the teratogen malformations in the baby. Next, moving on to the psoriasis. So there will be different types of the psoriasis. First, the plaque psoriasis. This is the most common overall. The patient will be having this extensive plaques on the extensor region. Okay, common areas, elbows, knees, and the lower back. Next, guttate psoriasis. This is seen in the trunk, typically in the children and the young patients post-infectious. This is the guttate psoriasis. Next, inverse psoriasis, especially in the skin folds, friction, and sweating, which will be seen. Next, pustular psoriasis. Pustules is present in this patient. Fever, chill, high fever, WBC count is seen in the inflammation. Next, another two types, erythrodermic, widespread red inflammatory skin, and sometimes it can be life-threatening complication. Nail psoriasis. So these are the changes. You are going to see pitting, right? This kind of pitting will be seen. Leukonychia, like the changes will be seen, and red maculae in the lunula. Okay, red maculae in the lunula, crumbling and destruction will be seen. Trichonychia, and also solvent patch or the oil spot. This is the oil drop sign can be also seen. Onycholysis and hyperkeratosis, splinter hemorrhages. These are the nail changes will be seen in this patient. Next, this sign is known as a Auspitz sign. This sign is known as a Auspitz sign. And what is this X-ray showing, guys? This is the psoriatic arthritis. Psoriatic arthritis. So psoriatic arthritis patient will be having this. So like this, there will be destruction will be seen in this patient. Okay, pencil like structure or the sausage like structures will be seen on the X-ray. And what is the treatment for this patient? The first drug that we can give is the calcipotriol, the vitamin D analogs. Okay, vitamin D analogs. If it is not working, then we are going to proceed for the methotrexate or the monoclonal antibodies for this patient. Okay, this is the overview of the psoriasis. Next, moving on to the placental types. So there are the two types placenta. One is the maternal show placenta. Here you can see the origin here. It is the decidua basalis, and on the fetal side, it is the chorion frondosum, which will be shown as a shiny color. 4/5 of the placenta, along with this tube that we are seeing here, right? This what do you say? Umbilical cord. You are going to see on the fetal side only. Okay, that is going to be seen on the fetal, and the reddish color and deciduous basalis is seen on the maternal. Next, you have the types of the placenta, multi-lobed. Okay, this is the multi-lobed, and here you can see this is the succinate lobe. This is the bilobeta. Sorry, this is the bilobeta. Two lobes are attached. Succinate lobe, accessory lobe. One big one and one small one. That is the succinate lobe. Next, this is the circumvallate. You are going to see there is a thick double layer that is present. That is a circumvallate. Next, marginal battledore. Here you can see very margin. It has to be in the central, but the umbilical cord is in the margin. Next, filamentous. So the whatever the structure of the cord that will be attached to the chorion only, the membranes only it is attached. So this is known as a filamentous. Again, here you can see the battledore insertion, and here filamentous type of the insertion. Battledore is a corner, filamentous is to the membranes. Circummarginate, circumvallate thickness surface, no thin, then it is a marginate. So next we are going to discuss about the PIH, guys, pregnancy induced hypertension. So pregnancy induced hypertension is divided into the four different types. One is gestational hypertension. What is meant by the gestational hypertension? The patient is suffering from the hypertension. That means more than 20 weeks after age of gestation, there will be 140 by 90 mmHg on the two occasions. On the two times you are going to see. So this is the gestational hypertension, and no proteinuria is seen in this patient. Next, pre-eclampsia. So pre-eclampsia patient is going to have the same features. More than 20 weeks, and the patient is having the more than 140 by 90 mmHg on the two different occasions. Along with that, there will be proteinuria is seen. Okay, next, there is a chronic hypertension. So this chronic hypertension, less than 20 weeks of age of gestation, more than 140 mmHg, 90 mmHg will be seen. So this is the chronic hypertension. Then chronic hypertension with preeclampsia. So this is the superimposed condition, right? This is known as a superimposed condition. So less than 20 weeks only. Okay, but there is a organ damage such as proteinuria is seen in this patient. Okay, next, preeclampsia can be severe, preeclampsia can be mild. So preeclampsia severe, patient must be having the HELP syndrome, or patient must be having the eclampsia or end stage diseases. Okay, end stage organ or the multi organ damage will be seen. So mild, only the patient will be having the proteinuria and patient will be having the raised BP. Okay, this is how the patient PIH will be seen. Next, how can we prevent? For the prevention of this one patient, we can give the patient of the 100 mg oral aspirin can be started. Okay, but if it is a serious condition, how to decrease the BP? If the patient is in the emergency situation, you have to give the IV labetalol. IV labetalol is given for this patient. If this patient is having the oral, if you have to start the oral, then alpha methyl dopa can be started. Alpha methyl dopa can be started. If the IV labetalol is not decreasing, then go for the IV hydralazine can be started. What are the drugs that is contraindicated? ACE inhibitors, herbs. Okay, these drugs are completely contraindicated in this patient. Okay, this is the important points that you have to take note. Next, the patient is having the eclampsia. If the patient is having the eclampsia, so in this eclampsia, what is the drug of the choice that we can give? MgSO4 should be given with the use of Pritchard regimen. Pritchard regimen, both the patient IM and IV both are given to decrease the seizures and to also prevent the seizure. Okay, next, management. How you are going to treat this patient? Management. If you see this is a patient is having the mild condition. Let's say the patient is having the mild or gestational hypertension. If it is a controlling, then what you can do, we have to go for the patient at least more than 37 weeks of the gestation. Age of gestation should be gone. Okay, until then we can go and we can go for the induction of the labor. But if it is a severe, or if you see the eclampsia, or if you see the HELP syndrome, what you have to do, you have to terminate the pregnancy immediately, regardless of whatever the AOG, you have to terminate this pregnancy. But what are the important things that you have to take note when you are terminating the pregnancy? Give the patient labetalol, give the patient labetalol and MgSO4, and if it is patient is less than 34 weeks, give the steroids, and also antibiotic prophylaxis should be given. Okay, this is the termination procedure that you have to follow. Okay, this is the important points that you have to take note, guys. Next, moving on to the patient, those who are suffering from the APH. What is meant by the APH? The come again, this is for the antepartum hemorrhage. Okay, first we are going to see the patient, those who are suffering from the previa symptoms will be the patient will be having the no pain, but there will be bleeding. Okay, painless bleeding will be seen. It's like a warning. Yes, something is going to be happen for this patient. Grading will be the placenta here type 1, it is the distance will be more than 2 centimeters, and type 2 is almost the os, and type 3 partial covering, type 4 is complete covering. Okay, this is how the patient will be presented. Next, what is the treatment that we have to go first? First, if the patient is having unstable vitals and fetal distress, and you have to terminate. And how can you going to proceed for this patient? Caesarean section is the choice. If the patient is stable, if the patient is stable, then what you can do, you have to follow the McAfee regimen. This is known as a McAfee and Johnson regimen. So in this, you are going to monitor the fetal and maternal, and at least try to delivery by 37 to 39 weeks and go for the LSCS for this patient. Okay, this is the protocol for the stable and unstable. Next, here you can see this is the abruptio placenta, and abruptio placenta we see there will be a severe pain and also bleeding also, painful bleeding. Abdominal pain will be seen and also painful bleeding will be seen in this patient. Okay, but abruptio placenta will be highly risk for the DIC, disseminated coagulation will be seen in this patient. Further, to prevent that complication, what we can do for this patient is again check the vitals. If the patient vitals is stable, then you can go for the, if the patient vitals is Just if it is the 34 weeks of the gestation, go for the induction of the labor. Okay, but if it is less than 34 weeks, then we can go for the expectant. Again, monitoring should be maintained. If it is unstable, terminate. And again, here also we are going to go for the NVD only. Okay, if it is a stillbirth or patient is intrauterine death, then also NVD and induction is should be done, not the cesarean section. Next here, this is the condition of the vasa previa. So vasa previa, the patient likely to be no symptoms. Okay, no bleed, no pain. Only the sign that you are going to observe is a fetal distress. Fetal distress will be seen. What is the most common cause for this one, guys? Velamentous placenta. Just now we see the velamentous placenta above, right? Velamentous tube that is going to cause. And the treatment is immediate termination. Whether you are going to do the cesarean section, whether you are going to go for the NVD, guys, NVD is contraindicated here. Okay, so you are going to do the immediate cesarean section for this patient. And here you can see this is the another condition, placenta accreta, where the myometrium is going to be concised. Placenta increta, the myometrium complete invasion is seen. Placenta percreta, surrounding structures. So for this patient, the most common cause is the Neetha Butch layer. So this Neetha Butch layer will be present in the placenta. This is absent, guys. So that's why this is the cause that will be pertaining. And the patient will be having the history of previa plus cesarean section. Okay, and treatment, you can go for the cesarean section, and then immediately if the family is completed, do the hysterectomy for this patient. Do not remove the placenta, directly do the cesarean section and the hysterectomy. Next, PPH. So in the PPH, you have to understand two different types. Okay, first, PPH can be less than 24 hours, which is known as a early, and most common in the early is the atony, uterine atony. And if it is a more than 24 hours, this is known as a late PPH, and most common cause for this is the retained placenta. Retained placenta. Okay, first we are going to go for the uterine atony. Let's see uterine atony. So the most common cause for the uterine atony is the tone. Okay, the tone is increasing only. That's why the patient cannot get the relaxed and severe pain. So this is an emergency situation. First of all, you have to resuscitate whatever the loss that is going on. Okay, then do the massage. Uterine massage should be done for this patient. Okay, bimanual massage should be done. And along with that, you have to start the patient on the drugs. What are those drugs, guys? Oxytocin, okay, methargine. Methargine can be given, carboplast, and also misoprostol. These drugs can be given for this patient to control. But if it is still not controlled, then you have to infuse the Bakri balloon catheter. So in the Bakri balloon catheters, infuse the at least 500 ml of the NS and insert into the uterus. Again, still not controlling, then go for the surgery. How? B-Lynch sutures. The tight sutures will be wrapped for the uterus. Still not controlled, then go for the ligation. So how the ligation is done? First, you are going to proceed for the uterine artery. If it is not controlling, then ovarian artery you are going to follow. If it is also not controlling, then we are going to follow the vessels of the main vessels, whichever coming from the main pelvic arteries, we are going to ligate. Even though it is not controlling, then we are going to go for the subtotal hysterectomy. This is the last choice for the subtotal hysterectomy. Even if it is also not controlling, then we have to going to wrap up with the pack with the pressure. This is known also umbrella pack that you are going to follow. Okay. Next, another condition, uterine inversion. Uterine inversion, the most common cause. What could be the most common cause, guys? Manual error that is caused here. Okay, so immediately the patient will be having the hemorrhagic shock, but as soon as possible it is progressed to the neurogenic shock. Okay, if they ask what is the cause of death, then it is a neurogenic shock. Okay, so there will be a globular mask suddenly that you are going to see at the region of the uterus. Okay, how you are going to treat? Please stop the drugs. Whatever the drugs you are going to give, please stop them, and especially stop the oxytocin. Okay, next, what you are going to do is insert uterus manually by your hands. You have to insert, which is known as a Johnson technique. Okay, and after that you have to give the patient tocolytics. Okay, tocolytics, which will stop the contracts, and then sorry, you have to give the tocolytics, so it will stop the contractions, insert the uterus, and if it is not going to inserted by, then we are going to proceed for the abdominal surgery. We are going to proceed for the abdominal surgery. Okay, and if it is controlled and inserted normally, then it is good. In the abdominal surgery, we are going to proceed. Even though if it is also not controlling, the patient family is already done, then go for the hysterectomy. Okay, that is how we are going to proceed. Once you are done with the manual replacement, give the oxytocin only after inserting inside it. Before that, you have to stop. Okay, this is after. Next, moving on to the Parkinson's and the Alzheimer's. Okay, these are the another two important parts that you have to take note. Okay, so first see the Parkinson's, guys. In the Parkinson's, the most important thing, remember, this is going to be caused in the patients, those who are more than 60 years, right? More than 60 years, you are going to see the Parkinson's condition. What is the most common cause? This is due to decreased dopamine. Okay, this is due to decreased dopamine. But if it is involved the young patients, the genes that is involved is the chromosome 4 or chromosome 6. Okay, this is the PARK1 gene. This is the PARK2 gene. Autosomal dominant, autosomal recessive. Okay, they are going to show this so-called synclinopathies that will be seen in these conditions. Okay, this is the type of the Parkinson's disease where you are going to see the alpha synuclein on the Levy bodies. You are going to see this Levy body dementias and ubiquitins, tau proteins. These are the present here, and this shuffling gait will be seen in this patient. What is the tremors? The tremors that is associated here is the resting tremor, and also patient will be having the pill rolling tremor. Okay, this is how you are going to see this rigidity, especially the rigidity known as a lead pipe and cogwheel rigidity will be seen in this patient. Okay, and over the time, if it is left untreated, there can develop the akathisia and also akinesia, and eventually leading into the dementia. These are the symptoms that will be seen in the patients of the Parkinson's. Okay, next, moving on to the another condition, Alzheimer's. Right, in the Alzheimer's, this is the most common type of the dementia overall. Okay, and this patient, again, more than 60 years of the age, males are more commonly affected. If it is a children, Down syndrome. Why? Because 21 chromosome, which will be consisting of the alpha amyloid, this is also cause for the Alzheimer's disease in the young age. So what you are going to see on the MRI, you are going to see this cortical or the hippocampal atrophy. Okay, the atrophy will be seen in the brain, and along with that, this is also seen. What are these guys? Amylin beta analogs, synuclein, tau proteins, neurofibrillins. This will be the tangles that will be seen in this condition. So on the histopathology, you are going to see the neurofibrillary tangles, and also ApoE4 analogs and beta amyloids that will be present in these conditions. Okay, next, we have to know about the Parkinson's treatment and also Alzheimer's treatment. Okay, first, what is the cause here, guys? See, this is the condition that is decreased by the most important part, that is the dopamine decrease. So you have to give the patient with the dopaminergic agents. So the drug of the choice for this patient is the levodopa. but levodopa having the many side effects. So to add that, to decrease carbidopa, okay, levodopa and the carbidopa is given as a treatment for this patient. Okay, that is the one drug you can give, and along with that you have to add the another drug, that is the selagelin. These selagelin is the MAO-B inhibitors. These are the MAO-B inhibitors. Okay, this can be also added for this patient. And to decrease the tremors, we can also add the benzatropine. Okay, benzatropine can be also added for this patient. Okay, this is how we are going to treat this patient with this condition. Next, here in this condition, it is actually due to acetylcholine decrease. So you have to do the acetylcholinesterase inhibitors. So the drug of the choice for this patient is the donepezil. Okay, along with that rivastigmine. Next, NMDA agents like NMDA receptor antagonist, that is memantine. Okay, memantine can be given for this patient. Okay, this is the treatment protocol for the Alzheimer's and also Parkinsonism. Next, let's move on to the breastfeeding. Okay, so in the breastfeeding, you have to see this is how the proper breastfeeding is given for the patient. So how the mouth should be covering the areola and lips, the lower lips to be flanged out, and this is the position that you have to maintain for the baby. Okay, next, another thing, how many months is the exclusive breastfeeding? 6 months is going to be exclusive, and 6 plus 2 years, this is known as a complementary. After 6 months, this is known as a complementary feeding that we are going to start. Okay, next, this is known as a colostrum. This is known as a colostrum. Increased IgA levels will be seen in this one. So this one, which will be increased protein and balanced fat will be seen. So here more fat will be seen. Very good for the retina and the CNS product, CNS things. Next, breastfeeding is absolutely contraindicated. Breastfeeding is absolutely contraindicated. Galactosemia and also lactose intolerance. This patient we are not going to give. Next, relative contraindications like HIV, TB, CMV, or active herpes lesions, and those who are having the chemotherapy. This patient also we are not going to give. Actually, chemotherapy is absolute contraindication, chemo or the radio, because this radioisotopes chemo can be transmitted. So that's why it is an absolute contraindication. Okay, this one. But actually, this will be associated with two hormones. One is the prolactin and other one is the oxytocin. Okay, so prolactin and oxytocin is going to play the major role here in the production of the milk for the mother. Okay, next, if they are not having this reflex, okay, first suckling reflex that is present. When this suckling reflex will be presented at more than 35 weeks. But what about the patient, those who are less than 35 weeks? So less than 28 weeks born babies, we have to go for the total parenteral nutrition. That means via IV you have to give 28 to 31 weeks. It is given for the NGT tube. Okay, next 32 to 34 weeks here with the help of the spoon or paladile, katori spoon or the paladile is used. More than 34 to 35, then you can give the breastfeeding exclusively for this patient. Okay, next, in the breastfeeding we also have to take note of the important ingredients, or let's say important of the nutrients. Okay, what are deficient and what are important here. Okay, so sorry guys, so mostly the breastfeeding milk which will be containing of the lactose, right? This is the lactose that will be important present. And how about the casein and the whey? So the casein and the whey, which will be 40:60 ratio, that will be presented. And IgA, what we discussed, and also there will be proteins that are present like DHA, and also PUFA. These fatty acids also present, and these are important for the brain and retina development. Retina development. When it is comes to the vitamins, vitamin D is low. Okay, vitamin D is low. That's why what we are going to do, the vitamin D should be given for the mother. Next, iron is low, but its bioavailability, whatever the observation, which is normal. Okay, that is also important. Okay, immunological lactoferrin, which is a bacteriostatic. Okay, immunologic, these are also presented. So all these are going to be importantly present in the breastfeeding ingredients. Next, moving on to the malaria. Here you can see malaria, how it is given, guys. It is given in the different dosages. For example, all the states for the malaria patient, we are going to give the chloroquine on the day 1 10 mg, day 2 10 mg, day 3 5 mg. Primaquine to prevent the vivax relapse 0.25 mg per kg for 14 days. So patients, those who are suffering from the falciparum in the northeastern regions is different, remaining states is different because of its resistance. Okay, for that patients, we are going to proceed first. We are going to give the ACT therapy, artesunate, artemether, and lumefantrine for the day 1 along with the primaquine. Okay, so next, in the falciparum, in the remaining states, how we are going to give? There the drugs are changed. Artesunate, sulfadoxine, and pyrimethamine. This is how you are going to give. Okay. Next, how these drugs are given in the northeastern, ACT therapy. In the remaining states, ACT SP therapy is given. Next, falciparum patients, those who are in the pregnancy period, primaquine is not contraindicated, and quinine is given in the first trimester, and ACT AL, ACT SP is given in the second and later trimesters. Next, prophylaxis. For the short term, the drug of the choice is the doxycycline. Long term, mefloquine. 100 mg per daily for the short term, and more 250 mg weekly once is given here. So during the travel, yes, you have to take. During the travel, you have to take up to 4 weeks after, for the both the prophylaxis. Next, moving on to the malaria indicators. API, annual parasite incidence, best for the malaria impact indicator. ABER is the best indicator for the prevalence of the fever and operational indicator. Next, SPR, slide positivity rate. This is for the outbreak indicator, and infant rate is for the recent transmission indicator. Okay, again, API is for the malaria impact, ABER for the operational and the prevalence, SPR is for the outbreak, infant is for the transmission indicator. Next, coming to the vectors. So here you can see the difference between the Anopheles, Aedes and the Culex mosquito. Okay. Not only that, you have to understand how these diseases are transmitted from these conditions. Okay. So first of all, here you can see this picture. Here you can see these are the causes we will see from these vectors. So this is the Reduvid bug. Reduvid. This is the Reduvid bug. What it is going to cause? It is going to cause the trypanosoma. Right? This is the sandfly. So sandfly is going to cause the leishmania. So if the head is small, body is big, then this is the soft tick. This is known as a soft tick. If the head is big, it is a prominent, then it is a hard tick. So soft tick is going to cause the scrub typhus. Hard tick is going to cause the Karnataka forest disease. Next, this is going to cause the plague. What is this one? This is known as a flea, is Xenopsilla Cheopsis. This is the lice which will be causing the pediculosis. Right? This is the types of the entomology. Next, see the differences, guys. First, what are the causes which will be associated? Malaria due to Anopheles. Aedes is going to cause the dengue, yellow fever, and also it can cause the Zika virus, chikungunya. Culex is going to cause the filaria. Filaria it is going to cause commonly, and Japanese encephalitis. Next, Anopheles mosquito. is actually going to stay in the clean water. It is going to stay in the clean water, and it is going to stay in the stagnant water. This culex is stay in the very dirty water. Next, coming to the another one, the larva. Larva is always boat shape. Here it is boat shape. Here there will be cigar shape, and here it is going to dirty water. Clusters. They look like clusters. Okay. Next, on the body there will be inclined position, and spots on wings. You are going to see the spots on wings like this. The spots will be seen. And here in this page, in the Aedes tiger mosquito, so stripes will be seen. Okay, the stripes will be seen. Stripes on body will be seen. So this is completely brown color, brown hunchback, which will be seen here. Okay, next kilometers. How much kilometers they are going to do? 2 to 3 kilometers, especially night bites. And here 100 to 200 meters, mostly night and day. Okay, night and day will be seen. Midnights mostly it will be seen. 10 kilometers also by the Culex mosquitoes, both morning and evening. Okay, not in the nights. This is the difference between the Anopheles, Aedes and the dengue. Next, they are the barriers that we are going to use. First, physical by the asphyxia, which will cause due to oil. Okay. Next, chemical. These are for the eradication. Malotine, Paris grass. Paris grass is for the stomach poison, and this is for the skin or contact poisoning. Next, biological. This is going to be fish, Gambusia fish. Okay, Gambusia fish. Okay, these are the important points for the vectors and their eradication. Next, moving on to the trauma. In the trauma, you have to know about the primary survey. A for airway, B for breathing, C for circulation, D for disability, E for exposure. And secondary survey, head to toe, ample. A for allergy, M for medications, P for past medical history, and L for the last meal that you have to see. And next, triage. Coming to the triage, codes and colors for the trauma patient. Okay, that also need to be understand. First, triage patients. This is a very important, guys. Red is going to be emergency. Okay, that patients need to be treated immediately. Okay, immediate treatment should be given for this patient. Okay, next, yellow. Yellow can be delayed. Yellow can be delayed, but treatment is should be given. Next, green. Okay, but at least you have to stable. Next, green is minimal. This is can be done in the OPD also. Okay, can wait or the self ambulate. Next, black. The patient is already dead. No treatment. The no resuscitation can be also done. Okay, this is for the triage of the red, yellow, green, black. Next, some of the scores. Q SOFA, hypotension, altered sensorium, tachycardia. Shock index, heart rate by the systolic BFE. Revised shock index, heart rate by the mean arterial pressure. Okay, next. Here you can see, this is the, here you can see the picture of the different cannulas, right? So in the cannulas also, what is the important point that you have to remember? What is the gauze number? Okay, how much is the gauze given for the each color code? So better remember this way so that you cannot forget. Okay, first, lava, orange, which is lava is in the orange color, and gray, soil, green, this is the plant, or we can say grass, and pink is for the flower, blue for the sky, yellow is for the sun. Okay, then other than that, violet. So in this sense, this orange is start from the 14 gauge. Okay, and gray is the 16 gauge. 7, this is the 18, this is the 20, 22, 24 and 26. This is the highest. Okay, so this both are used for the children, and this is commonly used for the blood transfusion, and here this is for used for the adults. Okay, so this is how the cannulas has to be remembered. Next, this is known as a Pringles maneuver. Pringles maneuver. So done, especially in the trauma, you are going to stop this blockage. Arteries like hepatic artery, hepatic vein will be blocked to control the hemorrhage. So question here, for the blood transfusion, what you are going to use? Green cannula you are going to use. Next, fifth, the last topic for today, that is the BLS algorithm. First, you have to see the patient breathing is present and patient is pulse is present. Then you are going to proceed for the further treatment as needed supportive. If you see the patient is does not have the breathing but pulse is felt, what you can do? Give the rescue breathing if you can, and if the no pulse, start the CPR or give the patient required. If it is a opioid dosage, give the antidote. If it is not due to that, then give the oxygen. But no breathing, no pulse is left. What you have to do? You have to start the CPR. How you are going to give? 30 is to 2 ratio. 30 compressions, 2 breaths, and start the AED. Defibrillator has to be started. Once the defibrillator is started, then check the rhythm. If it is a shockable, give one shock and do the CPR for the 2 minutes. If it is non-shockable, then resume the CPR and immediately follow if the patient is rhythm is present or not. This is how we are going to proceed for the patients of the BLS. So guys, this is how we completed the part 2, and tomorrow we are going to discuss the last part of the remaining 50 topics. Please don't forget to watch the part 1 and part 2 and part 3. I am telling you guys, this is going to be really helpful for you guys for the examination. Please stay tuned and watch the part 3 and give your best. Until then, those who are to new to this channel, please do subscribe and share with your friends. And happy preparation. See you guys tomorrow.